before to talk about the current situation, what will be our plan for, I am Juan, the president of the Amyloidosis Alliance. I would like to have a look in the back only for some minutes to tell to you how we reach, how we arrive to establish the alliance. Well, shortly in 2015, we have been invited from the French Association in Paris for they had the annual meeting, and I recall that we have other friends, Sonia Guterres Nadal from Spain, we have Jorge Nieto from Portugal, and we have also Fabio Almeida from Portugal. And I may say that since that moment, I really understood that there were the necessity to think about, to do something international. Probably at that stage, we think, to be honest, a little bit more European. Later change, unfortunately, because our plan was more big in a certain sense. Later on, we start with my attempt to establish one association in Italy, but as you may imagine, it's not easy to prepare the bylaws, the statute that is the important step for each association. So I failed, and later was the French association with François Fercot and Jean-Christophe Fidalgo to take the lead. And in 2018, finally we established in June the Amyloidosis Alliance, the Voice of Patient. So after this first starting, I would like to say the three associations that start were the AFCA, the French Association, the SAN, the Netherlands Association, and also the FAMAY, the FAMI, that is the Italian Association. Since the beginning, we had clear in mind that this reduced number was only to be operative for us to work about the statute, but our idea was to enlarge and to welcome the other association. In fact, as you may see on this slide, currently we are 24 countries all over the world. So my first idea, as I mentioned, to be only a European was not correct, fortunately. And now we are quite everywhere, but we would like to enlarge and to welcome other associations, obviously, that would like to join us. So, which are shortly the division of the alliance. In this, we have three messages that important for us. It's all the patients with the amyloidosis will be diagnosed as early as possible, because you know our disease is a disease that became progressive with time, and if we reach the diagnosis in time, is better. Also, that each patient may receive the highest standard of care, whatever it is, in which place of the world is resident, and also because this may allow to the patient to reduce the burden of the disease. What we would like to achieve is to raise awareness, to spread information at all levels, frankly, not only with the health care professional, but also with our patient association, with the pharma, but also with other communities. So we try to do our best to do this at the level of the international like alliance, and also each association locally in the national, and also to promote again the early diagnosis and the need to provide the best care, and with the focus to highlight and to reduce the social of the burden for patient and caregiver. I would like to to give just short about the caregiver. In the previous meeting, the fourth that has been organized in Madrid, we had a very emotional session with 3 patients that give their testimonies and make us to understand again, if it should be the necessity, how important is the role of the caregiver. So we are more focused on them because it's really important what they do daily to support the patient. And again, how we work. Obviously, the Alliance is what is called an umbrella association. So when, if you consider in your national association, you have the patient that are the person, individual that are the members. For us, instead, our members are the patient organization. And our idea was, since the beginning, in fact, was Amyloidosis Alliance, the voice of patient is also in our logo, is to bring the patient voice, and also in the visual, when we decide the logo, is the magnifier, the megaphone that really to speak louder and to try to attract the attention about our needs. And again, some highlights for now we come back to currently. Some highlights related to 2025. We continue with the World Amyloidosis Day that we established in 2021, and in 2025 was the 4th edition. And for us it's important because it gives us at international level and national level to raise awareness about all type of amyloidosis. Also, we have this year we launched at the end, to be honest, of last year and also in November. And this year, from one idea of our previous director, Agnes Farrugia, we launched the AmyLife that for us was very important because it was a survey focused on the question for the patient and again for the caregivers, and we have some information very important from us from this. Also, when we met with the organization last year in Rochester for the ALSA meeting, we start thinking about the necessity to look for us in the country where there will be the necessity to help and assistance to help them to raise to get the cure. And we focus on LATAM, means Latin America, and we started a project also with the pharma companies that are our partners to start a project to understand how is the current situation and to improve there. And we start with the Brazil and with the Colombia. And also yesterday we have a meeting to go further about this. And also, each 2 years we organize a conference like this that for us, apart from the obvious, it's very important because patient and doctors, we want really that during the session, and I strongly invite you during today and also tomorrow sessions to be very participative to this session, because we have to take the great advantage to have the doctors with us in a different scenario, not in the hospital, so more relaxed, and please address to them all the questions that you want. We go again shortly about the World Amyloidosis Day that I mentioned. On the right top, we have the picture of the campaign of last year. On the bottom left, you have the 3 pictures that we have chosen for the campaign of this year. And again, Some few words about the AMI-Life that I mentioned to you. First of all, to talk about the numbers, the figures. We have was globally international, and we have the participation of 3,000 patients and 650 caregivers. And what I would like to say to you that you are present, to the other that are remotely connected, I would like to thank you very, very much, because your participation has led for us a great, great value, really, to understand how is the current situation. And there will be sessions where we'll go in more details, so I don't want to take more time than necessary. And of course, with AMI-Life, our idea was to, with this information, to prepare what is called a white paper document, and we have obviously country report and something also international when we aggregate the figures, and there will be some publication and posters. So I prefer to give only some news about this. And finally, just not to take more time than necessary, I would like to remind you we are on social, we have our social media manager, very active, that help us very much on this work, and I don't want to take more time than necessary, and I would like to quit and leave the floor to Rosaline Callaghan from Ireland, or if you want, from Donegal, because we know, and also to Dr. Juan Gonzalez Moreno, that will chair the next section. Thank you very much, and I hope that you have a very fruitful session during the day. Thank you very much.
Thank you very much, Giovanni, for that introduction this morning. My name is Rosaline Callaghan. I'm the founder of Amyloidosis Ireland. We currently have almost 1,000 people in our private Facebook group. I'm delighted to be the co-chair this morning on session 1. You will see from the programme, it's called Daily Life with TRANSTHYRETIN Amyloidosis. I am also a patient living with the condition. You will also see on the programme that at the end there is time for discussion and questions. I would echo what Giovanni has said, to take advantage of this opportunity to learn, perhaps not only for yourself, but to take it back to your communities. So the first person that I'm going to introduce this morning is going to cover the topic, a toolkit for patients living with TTR amyloidosis cardiomyopathy. This person will make his own introduction. He has a number of roles within the amyloidosis community. If you would give a warm welcome, please, for David Gregory.
Thank you for coming to this event. I am David Gregory, a trustee with the Amyloidosis UK organisation and a board director with the Amyloid Alliance. I'm also a patient with hereditary amyloidosis. My main talk today is to launch the latest document that has just been created with the World Heart Federation, which some of you have got today, and we've also got some more copies at the back, if you haven't received that yet. As an organisation, we have been working with World Heart Federation to raise awareness, particularly in the cardio area, which is getting a lot of attention, especially with the new treatments. 3 years ago, Jean-Christophe, our then president, was on the working group to create the policy document on amyloidosis cardiomyopathy. The new toolkit is the next stage of the process. Before I talk about the toolkit, I wanted to share one of the activities that the Amyloid Alliance has been involved with. A key focus this year has been sending representatives to the relevant congresses to raise awareness of amyloidosis. This includes having a booth to show we exist. Many of these congresses give charities free space for this. The events included this month's European Society of Cardiologists Congress, which had 33,000 delegates. But more interestingly to us is that there were 71 presentations, posters and abstracts on amyloidosis. I wanted to highlight that the disease is getting considerable coverage compared with previous years. Some of the talks were in big venues with up to 900 cardiologists listening to our amyloidosis doctors, many of them next door doing talks today. And we will hear from many of them tomorrow. They include several of our consultants, including Professor Fontana of BC, Dame, Garcia, Pavea, and Gilmore. This year, we have also sent representatives to the International Peripheral Nerve Society and the BSSH Hand Society. My message is the landscape is changing, and we need to all build on it and stand up and be counted as patient representatives. I encourage national organisations to go to these events nationally and talk to the delegates to help raise awareness in the areas where early symptoms are most prevalent. Finally, the biggest amyloid conference globally remains to be the International Society of Amyloidosis, known as ISA. Every 2 years we send representatives of that, and the Amyloid Alliance is invited to be part of this group and is showing positive collaboration. Last year they supported us with our Brussels AL conference, which was greatly received. Here are some of the pictures of the events. It was also great to go to the second Amyloidosis Ireland event, which showed how good a national event can be done. Well done, Rosaline and the team. I know many of you have your local national events, which is always good to hear about. I wanted to highlight smaller events of the hand conference where hand surgeons were being educated on the disease to understand carpal tunnel being an early symptom and what that may look like in the future. AL being a probable supporter to this. Interesting, AL is currently being tested to diagnose early outset of amyloid CM. This is done by listening to the heart, where wild-type patients produce a specific heartbeat that indicates early onset. Really interesting and quite exciting. Of course, AL is a massive challenge for society, but this could be well be one of the great positives. So just going back to the ESC conference, all these companies had significant amyloid presence, all raising awareness to cardiologists and educating them on the treatment developments and those that have already been developed. I will point out, like our conference here, there are limitations where patients can enter doctor areas, and we need to respect those rules. Being part of these events help build up further relationships with the doctors, pharma, and other like-minded non-profit organisations. A World Heart Federation patient toolkit for TTR amyloid cardiomyopathy. That's the main part of my talk today. This has recently had a soft launch, but is officially launched this weekend at our conference. And it just so happens that W Heart Federation is also their day next Monday. As I've seen on Facebook with some of the delegates here today, the toolkit is already being shared, which is great. It is targeted at TTR cardiomyopathy community, both wild type and hereditary. The object of the document is to support patients and caregivers with information about the disease, and equally important, to give practical advice on how to manage the disease. WHF is the body that supports global cardiovascular community. It has around 200 Heart Foundation members. So in the UK, as an example, we have British Heart Society of Heart Failure and Cardiomyopathy UK. They are part of the WHF. If you check the website, our own national country heart organisation, your country organisations will probably be on that list. The Amyloid Alliance joined it 3 years ago when we supported the first ATTR document. All of the Alliance global groups are part of it. So if you're part of the 26 countries, you can go onto that site and have a look. Sometimes they give funds for projects which you can also apply for. So watch that space on that area. Their targets are similar to ours at the Amyloid Alliance, which is to influence agencies, governments and policymakers. They build partnerships, raise awareness, communicate and exchange knowledge. So the toolkit will be really useful for newly diagnosed patients and those just starting to understand it. I think the majority of the audience here today know about ATTR Amyloidosis CM. The document simply outlines what it is by having a simple infographic showing what the disease does to the body and particularly the heart. The toolkit given has been created in 4 languages: English, French, Spanish and Portuguese. All of them are also on the WHF website and can be printed off. And the zapper's not going forward. This is when my wife tells me off for not pressing the right buttons. Okay, this is the front page. As already said, it's for both patients and carers. This disease is complex and it's important the patients become the expert, as you will constantly be explaining and educating doctors, nurses and people in general. We know that one well, don't we? The document has been made to explain about the disease to better understand it, and time goes on and how best to manage the progression. An important part of it is the second half of the logbook to help you monitor the symptoms. It will help you prepare for a doctor's visit. From my own experience, quite often you have a big gap between appointments, so it's really important to record what symptoms you are having during this time. The toolkit is worded for easy understanding and avoids jargon and complexity. We need to help the doctors to determine what treatments they may give. If you don't communicate, you may not receive the treatments that you need. We need to help the patients, as I've said, become experts. The document provides an overview of what the symptoms that you may have. As knowledgeable patients, we know this, but I'm sure we'll remember when we didn't. The key symptoms are in the booklet and are highlighted to support what to look for. It also helps to educate the patients that they may have specific symptoms and there is a possibility that other issues will follow. It will take away the element of surprise. Then we have a section on support groups, which may be the first time the patient sees this. It's so important that we get this information out to the patients as they need support from groups who are experts in their field. The groups are for both patients and caregivers. It must be recognised that caregivers need equal support in this disease. We're going to hear later from some caregivers' experiences and to continue to highlight the challenges that this group has. The second part of the toolkit is the practical part. which the patient can determine how to use. It's fair to say that there has been similar amyloidosis help documents of varying detail in the past, and I feel this one provides a comprehensive guidance focused on those that have ATTR cardiomyopathy. The logbook is also a self-help and educating document that will help the patient to learn about the disease. It's split into 6 parts, helping patients to manage their disease in a comprehensive and structured way. So some of the pages I'm just going to go through. Starts with emergency details, including important contact details. This is followed by your thoughts on what the symptoms you're having. So it's a very personal document. It will say when and how long they've lasted. It's an important document to have available to go and see your physician. Quite often patients go, as we know, in advance with no preparation, which may result, again, not getting the best treatments available. This slide provides an opportunity for you to record your medication and any challenges you may have with some of those. Again, a good subject to discuss that I certainly did not put enough thought into, but I do now. There is a wellness log for you to give your thoughts on a week's lifestyle, including how you feel. It also talks about what we eat and what exercise we may be able to do. It's also a reminder to look after yourself as much as you can in these areas. As a patient, where possible, we need to take personal responsibility on how best to manage our bodies. Every stage of this disease needs adjusting to what you can and can't do. If you have a disease, when changing your focus is something we need to face. Later today we've got some great talks on these subjects which are directed to amyloidosis patients. Again, I'm looking forward to learning something there. And then the final 2 pages, I think, are some of the most important guidelines. Preparing to visit the doctor, as I've said previously, we need to plan this. This not going there without asking questions. What are the things that you want to know? No question is silly if you are concerned about it, especially when you're just starting out this journey. The last element is highlighting how you feel mentally, something that perhaps we don't always think is important or want to admit to that we're struggling with. This is asking how you are feeling and why. So, this is the World Heart Federation contribution to raising awareness and supporting cardiomyopathy patients. This disease, because of treatments and developing treatment, is helping to raise the profile, and we need as patient organisations to do our bit to help every single one of our fellow patients and caregivers. So a little message here from the World Heart Federation that they'd love to hear from you, and we have some senior representatives at the back, Andrea and Shira. Just waved at me, that's nice. Here today, so if you have any questions, please do that. And a little bit about World Heart Day is on the 29th of September, which is next week. These days focus their activity where they can raise awareness that nearly 20 million people die from cardiovascular disease each year. And also a reminder, Giovanni, that World Amyloidosis Day is on the 26th of October. I would like to thank World Heart Federation for specifically producing the document, and thank you for being here today, and further build a great collaboration now and for the future. So in the interest of time, we're going to do the questions later, as Rosaline will tell me off for going over time. Thank you.
Thank you very much, David. As you said, we will have time later for the questions. Now it's a pleasure for me to introduce Professor Stefano Perlini. Professor Stefano Perlini is a leading expert in cardiac amyloidosis, working here in Italy in the University of Pavia. And he's going to talk in a very interesting topic about physical activities, which I like a lot, especially in patients with TTR cardiopathy. So please, Professor.
Thank you very much for the nice introduction. And I choose not to have slides. Sorry for that. It was just in the interest of trying to interact each other. My main bias is to have been involved in this disease with many patients and with Roberta Mussinelli, who is there for a very long time. So I learned a little bit about this disease with the patients. And this is very important because it makes the crucial point in learning how to deal with the disease and how to try to interact between human beings, one being the doctor, the other one being the patient, the other one being the caregiver. I was asked to talk about some of the aspects of cardiac disease. Let me introduce in general. As I saw before in one of the points, the main problem of the heart with amyloid is that it cannot fill properly. So this is the reason why the lack of filling will bring to a lack of possibility of having a reasonable cardiac output. There is the perfusion of our muscles and organs, and also a blood pressure that tends to be lower than normal. And this is something that really embarrassed the cardiologist, because this is something you don't need. So when dealing with physical activity, what I can do, what I cannot do, what is advised, just to have an idea of this basic physiology, I think is useful. The heart is stiff, cardiac output is a little lower, blood pressure can be lower. So this is one point we have to deal with. Together with this, and I try to follow in the interest of the translators, just the agenda we agreed, and I hope the translator are telling me I'm not too fast. Any feedback? I hope so. There is a lower capability to adapt to any effort that was normal before. I cannot climb the stairs as before. I cannot walk as before. I cannot lift weight as before. This is part of the physiopathology of this stiff heart. The stiff heart also needs a little higher heart rate. That is something it needs. So it's something I don't have to fight with. It's something the heart needs. So how to try to measure together this capability, this opportunity in daily life? Very often the doctors ask, or the nurses ask the patient to do the 6-minute walking test. That can be something very funny. It's like a race. But in the meantime, it's just integrating lung function, cardiac function, the capability of the blood to go around, just to have few numbers. That helps us in understanding the situation is a little better, a little worse, shall I change something? So the 6-minute is something that really helped me in understanding that if a patient is coming to the office and saying, I feel a little better because I can walk more, I can do more in my daily life, 6 minutes is try to quantify this a little bit. You know that doctors are always worried about quantifying and having scales, numbers, and you say, I don't care. But anyway, that's something that helps us. What can I afford in my daily physical activity? Can I say anything you like? Anything you can deal with? There is no limitation. Provided you don't feel too tired, your blood pressure is not too low, you don't feel dizzy. So for some of you, it will be a short walk in the park. For some other, and I know that a patient of us had his 100 jump from a plane. He told me yesterday, just because he was parachuting. So something, I cannot do that. A patient with amyloid can do that. So this is something there is no limitation. But there is something I have to be very aware. Something that amyloid heart cannot stand is a sudden rise in blood pressure or a sudden increase in heart rate. Meaning, you know it very well, and you taught me very well, you can walk, you can have a brisk walk, but running, especially uphill, is a pain. Lifting something because you want to move a table in your house is something difficult. Why is this the case? Just because the heart is stiff. And if normally can increase cardiac output 4 times, in amyloid it can increase cardiac output 3 times or 2 times. Is it bad? Yes and no. Obviously it is bad. I didn't want anybody to have this, but in the meantime it's something I can deal with. So what I can do in order to improve my fitness, that is something everybody likes. Patients, doctors, nurses, everybody. I can do anything, maybe on smaller session, not too hard, not pushing too much. I cannot run a marathon, but I can walk briskly 3 times a day, 4 times a day. Can I go to the mountains? Yes, provided I don't want to climb the Everest in 2 days. So let's be reasonable, but try to understand what I can do. Some patient is very feared about I cannot do what I was doing in the past. Or I want to stretch my capabilities to the maximum possible. And this is something that is very reasonable. The problem is that we have a limitation. So we have to live with that. So I see some of the patients very happy because they say, now I can walk a little bit more. I can do my housework a little bit more. Can I train more? Yes. Attention, whenever you stretch too much your cardiovascular system, when you want to do something that is too hard, weightlifting or running or going too much uphill. And obviously this is from the cardiologist point of view. And the cardiologists are very, they think only the heart is important. But you have to deal because some patients will have cardiac dysfunction, neurological dysfunction, orthopedics problems, blood pressure. So this should be tailored. There is no a single size for all. And we have to tailor together. Because in a patient in whom muscle, joints, neurology is a problem, I have to tune a little bit what I can do. Not stopping, as the cardiologists do, only to the heart, blood pressure and heart rate. Another issue that is important, we have to control blood pressure and heart rate. It may seem very strange because the cardiology normally is trained to lower blood pressure and to lower heart rate, to fight hypertension and tachycardia. Here the situation I learned is completely different. Because a little higher blood pressure, a little higher heart rate, it's helpful. Just because the heart has got the problem of not feeling properly, so if I give a small increase in blood pressure, a small increase in heart rate, this changes. This is the reason why we have to tune together not some of the disease-modifying drugs, the ones that are tackling the disease itself, but the side drugs, one being beta blockers. There is a lot of discussion in the cardiology area about beta blockers. My personal opinion is that I should give the lowest dose that is tolerated by the patient, because my goal should not be 60 beats per minute, 65 or 70, but will be, is your patient feeling okay? In some patients, I have no problem in saying that I skip beta blockers, that for cardiologists are something that should be given like tap water, just because it's hurting the situation. Or if one of the patients has got a pacemaker, I have to discuss with my colleague in electrophysiology to say the threshold should not be 60. Maybe it's higher. Recently, I had a patient who was very worried because he couldn't walk because blood pressure was too low. After a little, let's say, discussion/fight with my colleague in electrophysiology, we turned the pacemaker to 70 or 75, and he was so happy because eventually he was able to go to the park with his friends. Just because increasing heart rate a little bit was just giving him a blood pressure not of 95, but was 110. So this is something we have to deal with. Last but not least, how can we try to measure together how the situation is working? First, my question to a patient is, how do you feel? Your impression related to how do you feel in your disease. Second, I have to try to measure this fitness. So 6 minutes you walk, just to have an idea. And this is something that for us has become more and more important because in many trials, this has been shown to be one of the end points. A third thing, what are the markers of cardiac distress? Normally, we ask you to go to the lab to have your blood to measure BNP, NT-proBNP, or troponin I. Why? Because they help us a little bit to understand how the situation is, much more than we can have with the cardiac ultrasound. Because the time of changes of these biomarkers related to the stress of the heart is much shorter than the time needed to change something in the structure and function. So this is another tool that we have to share in the understanding. So we have to discuss a little bit, BNP is increased or decreased, what does it mean? And last but not least, since this stiff heart has got a likelihood to go into arrhythmias, namely atrial fibrillation, that sometimes is an arrhythmia that some patient feels, some patient doesn't feel. So it's important to check whether the rhythm, either with any device the patient has got at home, or with the visit in the clinic, or with the feeling you have, is changing. Why? Because if the patient is shifted to a different rhythm, first, I have to cope with the hemodynamic situation in a different way. Second, there is a risk of the formation of thrombi, and this is the need of anticoagulant. That is not a war against the patient, it's just to prepare in the best possible way the situation. So having said that, the events we also have to measure together are the number of times you go to the hospital, the number of times you need to refer to your doctor, not to say, hi, how are you, but because you have a new issue or a new problem, or the times you need to go to the emergency room, or the times you need to change therapy. And in the changes of therapy, there are always done for good, but in the meantime, they will challenge me in saying, is this worsening or improving? Is there a change? So this is something that I just want to wrap up, just to open to any question you may have in terms of cardiovascular fitness, just to say how important it is to understand together what is my perception and your perception of how the heart with amyloid works in order to understand how to tune in the best possible way the therapy. In the therapy, please keep in mind that since the heart is working in that way, the use of diuretics, the use of beta blockers, the use of other commonly used drugs in cardiology has to change, has to be tailored in this very strange situation. And I don't want any to touch upon the many, luckily many drugs we have now to change the disease itself, because this is another topic. Thank you very much. Later the question. Thanks.
Thank you very much, Dr. Perlini. Now I will introduce Professor Amanda Peltier. Amanda is a professor of neurology in the Vanderbilt University in Tennessee. And I'm very excited to listen to her lecture because she will talk also about physical activity now in polyneuropathy. And she is being an expert on autonomic disorders. So please, Amanda.
Thank you very much. All right, I did use slides and pictures. This slide is just to say that amyloid touches all parts of the nervous system, but especially touches every peripheral nerve in your body. So sensory nerves, motor nerves, autonomic nerves that go to your gut, can affect your muscle, affects the heart. That's a big topic to discuss on how that affects physical activity. So why do we care? Well, because you can have falls, you can have injuries, you can have decreased mobility, and that it makes it hard for you to do just basic things like standing up to brush your teeth or do your hair or take a walk or do things with your family. We already talked about dropping things with carpal tunnel or difficulty controlling your bladder, controlling your bowels, pain, etc. So there's lots of things that this disease unfortunately can do to your body. So what can we do? And I'm going to talk about all the different stages and kind of what you can do at each stage. So stage 0, just to remind everybody, is when you have no symptoms of nerve disease, you have no limitations, and you can do whatever you want. Obviously, I'm not going to spend a lot of time on that stage. Stage 1 is when you start having pain. You might notice your balance is a little more difficult. You might notice if the lights are down or if you're walking in a park on uneven ground, you might not be as steady as you used to be, but you can still walk around without using an aid. And then stage 2 is walking with assistance where you need a cane or a walker. Now, I will make a comment, and this is going to be very sexist, so forgive me, but I see a lot of patients, especially men, who don't want to use a walking aid because they don't want to be seen using a walking aid. Now, sometimes I see this with women too, but I will say more often my men, patients, and the problem is that if you fall and break your hip or something happens, you're going to look way worse. So please, please, please use your walking aid. And then some people do get to the point where they can't walk, but that doesn't mean you can't do anything. So, all right. So stage 2, stage 0, like I said, do whatever you can. Stage 1, generally there's a lot of things you can do. The one thing I'm not a big fan of is treadmills, because when you have some problems with your balance, if maybe you have some shortness of breath, if you feel like you're going to faint, doing this on a treadmill can be really dangerous. So not my favorite to do, especially if you're doing it by yourself and nobody's around. Elliptical machines, rowing, swimming, Now, weightlifting, obviously, as Dr. Perlini said, you might have, if you have a lot of heart issues, you might have difficulty lifting weights. So using machines where you're sitting and you're not having to worry about dropping something on your toes, also important. Tai Chi yoga for flexibility, all can be very helpful. Now, stage 2, so people who have a lot of balance problems, it might find it easier to sit and exercise. Also, people who have like back problems, like because a lot of patients will have spinal stenosis, and so, or if they have a lot of pain in their feet, and standing on their feet is very painful. Sitting, biking, sitting, rowing, doing things like that might be more tolerable and still help you to exercise and be mobile. And I'm going to talk about autonomic symptoms and lightheadedness in a bit. And then there's also seated yoga that you can do that helps as far as expanding your lungs and breathing capacity and doing exercises like that. Water therapy, if you have access to it in a pool, can be really helpful because it's gentle on your joints, it doesn't hurt your feet, and that can be a lot easier and better tolerated. Now, once you get to stage 3, doing more seated exercises, if you can use light hand weights, great. If you can't, that's okay. But doing seated yoga and deep breathing exercises, practicing transferring from the chair to the bed, to the shower, to the toilet, is very important. So doing those things, if you can have any motion of your legs, like having one of those seated little cycles that you can move your legs, just to move your muscles, that will also help swelling. It will also help, when you move, that also helps constipation too. And tell me if I'm going too fast. Now, if you do too much, sometimes that can make things worse, not better. So if you exercise and then you find that you can't get out of bed for the next 2 days, clearly you did too much. So grading how much you can do and trying to measure that is important. But on the other hand, doing too little is also bad. So that's why I call this the Goldilocks. Not too much, not too little. So because if you sit and you do nothing, then you will get weaker. You will have more pain, you will have more problems. And so trying to find that balance can be challenging. All right. Now, we don't have a lot of research, unfortunately, with physical activity and amyloidosis. So almost all the things I've pulled for this has been A, talking to our physical therapists, and 2, talking about data that we have from other types of nerve damage in diabetes, HIV, chemotherapy. But we do know that if you move, it will help pain. And so sitting is going to make your pain worse overall. So having some movement is helpful for your pain level. And then also in diabetes and other diseases, we know that exercise helps improve your blood flow to your nerves, helps improve growth factors to your nerves. So trying to move can be very helpful in that respect. But like I said, if you over-exercise, that can be almost as bad as doing nothing. So it is a trick trying to find the right amount. The other thing that I will say is that when you have problems with the autonomic nerves that control your temperature, you are not going to tolerate heat very well. So that's part of the reason why pool activities are nice, but also this summer, can be really challenging. So exercising somewhere indoors might be better. Avoiding the heat, going out in the morning. Sometimes the morning can be hard because a lot of people have lower blood pressures in the morning, but trying to avoid the hottest part of the day, very important. Like I said, I'm not a big fan of treadmills. And then also, as you have more problems standing or walking, having some place where you can sit. So like if you go to a park, either having a rolling walker where you have a seat, or like a cane that has a seat on it, or somewhere they have a lot of benches, can be helpful in case you feel that you need to sit down. And so pacing yourself, important. Unfortunately, this disease makes type A people who are go, 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 into type B people, whether they want to or not, which can be very challenging. Now, if you have autonomic issues and you have problems with your blood pressure, one, not everybody feels dizzy. I've had many, many descriptions over the years. Some people feel weak in their legs when they're standing for long periods of time. Some people get short of breath when they're standing for long periods of time. Some people, they notice their vision going out. So some people have different symptoms when their blood pressure is dropping when they stand up, besides just feeling faint or feeling lightheaded. So recognizing those cues and knowing that you have to sit down is very important. And again, doing things where you're just standing for long periods of time can be very challenging. Making sure you have water or something available, very important. And again, avoiding the heat, very important. There are sometimes companies that advertise a whole lot of different things, like TENS units that might help with the pain, but we don't know whether or not it will help or not. Infrared therapies, there's always things coming down the pike, and so just talk to your doctor. And then, like I said, last but not least, please, 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 like if you need a brace to help keep your feet, so that you're not skimming your toes and making you more likely to trip and fall, using a walker. My favorite is a walker that has a seat, so that way if you feel tired and you have to sit down, you have an instant seat to sit down. And then making sure that, if you're having problems, because, like I said, if there's not, as one of my doctors used to tell me, or used to tell his patients, nothing you have, a broken hip is going to help. And with that, I will tie up this talk, and just remember to try to keep moving and do what you can. But please, obviously talk to your doctor about what you can do. Thank you.
Thank you very much, Professor Peltier. For the next session, we actually have two presenters, even though there's just one on your program. We have Maria Cappello, who is a specialist in gastroenterology with the University of Palermo, and Jean-Christophe Fidalgo, President of the French Amyloidosis Association.
Thank you, Mr. Chairman, and thanks to the organizing committee for the invitation. And good morning, everybody. So I'm a gastroenterologist, and I will speak about digestive problems. Doesn't go? Okay, these are my disclosure. This is going to be the agenda of my speech. I will speak about the prevalence of digestive problems in ATTR. I will speak about the problem of the diagnostic delay and how to reduce the diagnostic delay. What are the examinations that the gastroenterologist will ask you to make a correct diagnosis? I will speak about drugs, side drugs, like the cardiologist said in the beginning of this session, because side drugs can help improving quality of life. Even if nowadays we have so many genic therapy which are going to be disease modifying. And in the end, I will just introduce a nutritional problem, and I leave the podium to Dr. Fidalgo, who is the president of the French Association, who will speak about some nutritional clues. So let's speak about prevalence. You know that ATTR is a systemic disease. I'm going fast about that. And these are the main GI problems, the main GI symptoms. The first is in order of frequency is unintentional weight loss. Then we have early satiety or diarrhea or constipation, nausea, vomitus. And fortunately, it appears in later stage. You can have also fecal incontinence. But overall, these symptoms can be present in 56 to 69%. And they are more common in the early onset ATTR. Well, there are some genetic mutations that are closely linked to GI problems, while some are not. And as you can see in this slide, I'm not going to go into the details. The V30 MET, for example, is very closely associated to GI disorders. Why the GI involvement? Well, the GI involvement is, like the neurologist said before, is due to the autonomic dysfunction. So this is due to altered motility mainly, but also the amyloid can infiltrate your bowel wall and give malabsorption or protein losing enteropathy. What is the problem with digestive symptom? The problem is for your gastroenterologist, because these symptoms are not specific, and if they appear in the onset of the disease, they can be misdiagnosed, because there are a lot of disease in the gastroenterology setting which come in differential diagnosis. And you know that nowadays the early diagnosis is more important, because you can start the disease-modifying drugs. Indeed, 17% of patients have seen at least 5 clinicians before getting a correct diagnosis if they present with a GI symptom. 57% of patients never receive a correct diagnosis, and patients sometimes are submitted to several endoscopies before getting a correct diagnosis. This is the problem, what we call diagnostic delay. And how to deal with that? Well, the first point is to increase awareness among doctors and among gastroenterologists. This is a paper in which I coordinated a group of Italian experts, and what we did found, together with Laura Obici, and what we did found is the awareness among gastroenterologists is not so good, it's really very low. So there is the need of increased awareness, and this is our fault. I think it's a task of the university doctor to teach about GI involvement in ATTR. How to reduce the diagnostic delay? Well, there are so many differential diagnoses. Your gastroenterologist is going to get confused, and symptoms are not specific. So what he must know, your gastroenterology, he or she must know, is to identify the so-called red flags. Yes, you can have nausea, vomiting, early satiety, you can have diarrhea or constipation, but you have to suspect ATTR when there are some red flags, like carpal tunnel syndromes, orthostatic hypotension, gait and balance disorder, in males erectile dysfunction. In this case, your doctor has to think about ATTR with GI involvement. The things I think are more complicated when the patient has diarrhea or constipation, because in this case, the most common diagnosis is irritable bowel syndrome. So how to deal with that? Well, a patient with diarrhea and or constipation usually has to do some stool culture to rule out infectious disease, celiac disease, serology, because celiac disease is very common and regards about 1% of the general population, thyroid hormones assay, because also thyroid disease can cause diarrhea or constipation. And if this is negative, then your doctor has to go forward, has to check for alarm signs, because if you have anemia or even increase of CRP or fecal calprotectin, or you have a low ferritin, then those make think about inflammatory bowel disease, for example. So the patient has to be submitted to colonoscopy or MRI enterography. But if there are no alarm signs, then your doctor is going to check for ROM4 criteria, which are the diagnostic criteria for IBS, irritable bowel syndrome. But in this case, your doctor has to check also for the red flags, which I mentioned in the previous slide. And in this case, it is possible to suspect a GI involvement in ATTR. Indeed, GI symptoms affect both nutritional status, and we will speak with Dr. Fidalgo about nutritional problems, and also they affect quality of life. What are the examinations your gastroenterologist is going to ask you if you have GI symptoms? Well, if you have upper GI symptoms, then upper GI endoscopy will be asked for. And to diagnose this motility, then maybe a manometry or gastric emptying studies will be done. If you have lower GI symptom, then you have to your doctor has to check for ROM4 criteria or do some serology for celiac disease, as I said before, or thyroid disease, check for alarm sign, and then ask for colonoscopy or MRI enterography. When endoscopy is done, which is the role of endoscopy? Well, endoscopy sometimes can be totally negative. So you have to formulate the suspect of ATTR, and this means that you have to take, the doctor has to take biopsies, even if endoscopy is totally negative. And what is important is not only to take biopsies, but also to take deep biopsies, even if there is an increased risk of bleeding. And also, is important the place where the biopsies are taken. I'm not going to detail in this paper, but this paper says that the biopsies must be deep, and there are some bowel sites which increase the diagnostic yield, like the duodenum or the rectum, because finding amyloid in those sites is much easier. And this has been recently confirmed in this paper just published in BMC Gastroenterologist. Anyway, when you have symptoms and you have the red flags, then we have to check for a TTR genetic testing because it's easy to do and can help in formulate the diagnostic suspect. Let's go to supportive care. Those are all the drugs, the so-called side drugs, which we can use to improve symptoms, and improving symptoms is really important in improving also quality of life. If you have upper GI symptoms like nausea, vomiting, early satiety, then prokinetics are going to be used. And sometimes, if symptoms are really severe, you have to combine different prokinetics, like domperidone, for example, or erythromycin. Even now, new prokinetics are going to appear in the market. Etopride is going to be licensed in Italy, for example. If you have diarrhea, then you have to use loperamide. The US doctors love opioid, but usually in Europe we don't use so much opioid. If there is an altered motility, sometimes antibiotics can be useful because you can have a problem of SIBO, a small intestinal bacterial or growth, because in those bowel, in the bowel which doesn't move, you can have an increase in bacteria, and so antibiotics can be useful. If you have constipation, then you have to suggest to your patient you need to drink more water, to introduce a bigger amount of fibers in the diet, and then use laxatives like polyethylene glycol, for example, macrogol, or sometimes also lactulose or other drugs like prucalopride or linaclotide. And again, these drugs can be combined if symptoms are really severe. Of course, the gastroenterologist has to do some follow-up visit, because even if GI symptoms are not present at the onset, can appear during the course. So I think a follow-up visit every 6 months to 1 year is going to be important. This is my small experience in Palermo. We have started to treat patients with the ATTR with GI involvement. As you can see, in my serious diarrhea is most common symptom, together with unintentional weight loss, followed by constipation. And this patient had a diagnostic delay of about 22 months, but improved after the gene therapy with patisiran. So the role of the gastroenterologist is very important at the diagnostic, making the suspicion of ATTR with GI involvement and doing the correct diagnostic workup. But the gastroenterology is important in your follow-up to manage also GI symptoms, to improve quality of life, and to monitor of GI symptoms. I will just introduce the nutritional problem, and the need in the multidisciplinary team caring for the patient of a dedicated dietitian. Why? That's because malnutrition, sarcopenia means the reduction of muscle mass and muscle function. It's very common, and also cachexia can be common in ATTR amyloidosis with GI involvement. Data in the literature are really scanty, but anyway, we can extrapolate some data from AL amyloidosis, and has been found that 65% of patients had malnutrition, and 74% have muscle wasting, and this is going to be very important to supplement this patient, and also with physical exercise. Of course, to assess malnutrition and to assess sarcopenia, you have to use appropriate tools that, like the bioimpedance analysis and also the MBMI, the modified BMI, which is the product of BMI and serum albumin. Unfortunately, BIA in ATTR amyloidosis has been not validated, but we can extrapolate from other disease. And when you find malnutrition, then you have to supplement the patient, and you will be asked to take vitamins, for example, vitamins or minerals, but if something is more severe, then you can use oral nutritional supplements, and the dietitian who is expert in this field can find the supplement which is better tolerated for every patient, because this supplementation must be tailored to patient need. And in more severe cases, even parenteral nutrition is important and life-saving in some cases. I'm not to speak about dietary advice, which is very important because dietary counseling can really improve quality of life. And I'll leave the podium to Dr. Fidalgo for dietary counseling. Thanks for your attention.
Thank you very much, Professor Cappello. And now Jean-Christophe Fidalgo.
Good morning, everybody. As you see, I'm following Dr. Peltier advice. I need a stick. I use the stick, and I am a man. So you can maybe worry a second presentation of on nutrition and gastrointestinal disorder, but don't worry, this is really complementary. Unfortunately, I'm not doctor. I would like to, but I'm a patient. My disease started 29 years ago, so I have a long experience with those disorders, and I'm sharing with you what I try to minimize those problems. So many patients are suffering from digestive problem when having amyloidosis, mainly diarrhea, constipation, sometimes both. It's creating extreme fatigue. And sorry, Dr. Cappello, but my experience with drug, it can be good in emergency, especially with diarrhea, but for a long time perspective, I don't feel that's really bring a real solution. So I will talk about 4 different approaches that I personally tried, and I don't tell you this will solve your issue, but you may try, make your own experience, and you will see the result. And maybe you can share with us your experience. First approach is the use of a natural product, which is which was known at the ancient Egypt. This is named blonde psyllium, or also ispagule. So that's a natural product. When you mix it with liquid, it has the property of swelling up to 40 times its volume. And this is forming a kind of gel, or name also mucilage. And this is this gel which is helping regulate bowel movements, whether for constipation and diarrhea. So what you need is to take a spoon of this product and then take a lot of water after that. So my current use is a tablespoon of this product. You can mix in a glass. I prefer to mix it in my mouth, so I put the spoon in my mouth, put some water, I mix, and I drink the whole water after that. Need to be careful not to to make a bad way, but if you keep that in your mouth quietly, then it's quite good. So you need to drink the whole day. I take only 1 spoon a day, but you may increase the dose if you want to see a stronger effect. What is very important is to avoid taking psyllium close to drugs. So you need to wait at least 1 hour before taking the psyllium and 1 hour after drug also. So if you take drugs in the morning and at noon, that's really in the mid-morning that you take the psyllium. So where can I find this product? So in most of the health food shops, you can start buying a small dose, something like 100 grams. And if you see this is effective, in my case, I buy up to half a kilo or a kilo because it's cheaper. So you need to be careful to buy a pure product with no additive. I was very happy last week because there was a neurology congress and a famous gastroenterologist, the Professor Carbonell, recommended this product after good feedback from the patient. So it's the kind of package of 1 kilo. Second point is intermittent fasting. So there is we talk a lot about fasting in the media to lose weight, but in that case, this is not the purpose. The purpose is to decrease inflammation and to rest the digestive system. So there are several forms of intermittent fasting. Some are 1 full day in the week, other one are twice a week. The one I found easier and simpler to follow is a fast period of 14 to 16 hours. So you have 8 to 10 hours to eat. When, especially during the fasting period, you need to drink a lot of water. You can eat drink with moderation, coffee, tea, herbal tea, but without sugar. And the idea is to really give no calorie to your body during this period. So, for instance, you can have dinner between 7 and 8 p.m. and then you can restart, you can breakfast at 10 a.m. Or, if you feel okay, wait till noon. So, drink a lot, and globally, it's better to avoid any sugary drinks, even the one with artificial sweeteners, and fruit juice. I mean industrial fruit juice. So compared to other diet when you have to deprive yourself of certain food, this is much easier to follow. And if you drink a lot when you start feeling hungry, that's quite easy to be used to it. So after a week, you should feel the first improvement. But you need to be cautious if you have a low blood pressure, especially during the fasting period. If you feel a bit dizzy, then resume eating and talk with your doctor about that. If you want to keep a breakfast, which is, in my view, better, you may have an early dinner, finish at 7 p.m. Then you can restart at 9. A goal, maybe? Let's talk about the third approach, which is chrononutrition. So the basic idea is to eat everything, but not at any time of the day. There are two principles to follow. First, you need to combine foods according to how quickly they are digested. So for example, you won't eat steak and French fries and take a dessert with a melon, because it's necessary to have a long time to digest the meat and the fries, and the melon is digested within something like half an hour. So when it's mixed with the main course, then it will start to ferment and produce gas. So if you like melon, you want to have it in the same meal, then you have it as a starter, and you wait at least 30 minutes before pursuing your lunch.
Jan, here, sorry. Jan, here. Please, 1 minute left, please.
Okay.
So sorry.
So on this picture, you can see the basic meal. So there are four meals a day. You have a salted breakfast with eggs, cheese, cold meat, and bread, but not white bread, sourdough or other. For the lunch, you can have fat proteins. You can have also carbohydrate food. You take a collation, a snack between 4 and 6 with fresh fruit, dry fruit, an handful of almonds, for instance, a drink, and then light protein, fish, chicken for the dinner, and as many vegetables as you like. If you have no problem with raw food, you can eat salads. If not, you can cook, but with healthy cooking, steaming, oven, and put a little fat on the gas. So last point will be the microbiome. So there is a lot of correlation now seen between disease and microbiota. Some Brazilian scientists observe a difference. Amyloid person and normal people have a different biome. So you can eat some lacto-fermented food. You can eat like sauerkraut, like Korean kimchi. Yogurt are good. As Dr. Cappello said, vegetable and fruits with a lot of fibers. So you can eat fresh or frozen, which are good. Sorry. And you can also eat garlic and onion. And there are some drinks also which are good for your microbiome. So the kefir, the kombucha, and I will please my friend from UK, Ireland, Germany, and Belgium. Also, some beer. I experienced myself having a small glass, not a pint, 20 centiliters of lager beer, and I feel quite good, less disorder, no impact. And I found this paper from Portugal, where they made a study with alcoholic and non-alcoholic beer. And in both cases, after 4 weeks, they saw an improvement in the diversity of the microbiome. A small glass, I said. Huh? Okay, so for who want, I have the reference of the paper. Yes, there is yes, last point is also twice a year I'm taking some probiotics. So I know there is a lot of controversy. Very few of those were proven as effective. I have good experience with one, and when I'm also traveling to exotic country, where I may get tourista, I take another variety of probiotics, and it's quite efficient as well. So I can share with that afterwards. So, as a conclusion, for patients who are suffering from digestive problem, it's interesting to follow what are prescribed by doctors, but I found that more as an emergency solution. And you can try one of those 4 approaches to minimize your digestive problem. Personally, I'm still taking psyllium. I try to follow chrononutrition, and I'm taking care of my microbiota. The intermittent fasting, I not do it every day, every week, but sometimes. So do your own experience, and on top of that, eat a healthy diet with maybe organic product if you can, to avoid pesticide, and avoid as much as possible processed food. Thank you for your attention.
Thank you very much. We are in a little bit in delay, so maybe we have 5 minutes for questions from the audience. I have some thoughts to share while people think in their questions. We have talked about the heart, we have talked about physical activity and also nutrition. I think in the daily clinics we don't talk about too much about these topics because we don't have usually time. And for me, it's very important to talk about also mental health that has been included in the toolkit. I think mental health is essential for everything because mental health is essential for doing exercise, and exercise is essential for mental health. Mental health is essential for autonomic control because it's linked to the autonomic nervous system and linked to a lot of symptoms that has been commented as digestive symptoms. So, and there is an actual pandemic of mental disorders, so we have to talk more seriously about this and to talk in every consultation about this, and should be also, of course, as has been referred in the toolkit that I found really, really interesting. And also another topic is talking about another organ that we don't usually talk, is about the muscle. We have talked about physical activity, but the muscle as an organ has been shown to have a lot of relationship with mental health, with quality of life, and I think that strength exercise must be a must for everybody because muscle is very related with this quality of life that we have been talking about. So I don't know if there is any question in the audience. Do you have any questions, Rosaline?
No, I was just going to say, if you do have a question, raise your hand, please. We have a microphone. There's a question over here, please.
Sì? No. Funziona? Ok. Buongiorno, mi chiamo Cinzia Onorati, vengo da Roma. Io avrei una domanda per il dottor Perlini. Quando parlava di rigidità del cuore, si riferiva all'emiblocco o un'altra situazione? E una seconda domanda invece per la dottoressa Peltier. Il mio corpo, oltre al formicolio, grampi e tutto il resto, ho una sensazione continua di vibrazione fortissima. Quando sono stanca, in una maniera esagerata, vibra, il mio corpo vibra in tutte le sue parti, in tutti i suoi muscoli, fino alla pelle, tutto. Ecco, queste due domande, se è possibile.
I reply in English for the translation. Thank you very much for your question. Stiff heart means that it's not elastic. It cannot feel properly. So stiff means that the problem in feeling the heart is much more difficult just because amyloid is changing the physical property of the muscle itself. It's like a chamber that you cannot dilate. This relates to the way the pump is functioning and eventually also on the electrical conduction. But the main problem at the beginning is just that the heart has some problem in filling properly and in filling nicely. We are done in such a way that it's very easy to fill the heart and it's very easy to empty the heart. In this disease, it's much more difficult to fill, and thereby it's much more difficult to have the outflow. I hope this can help.
Can you translate the second question?
Pardon me?
Can you translate the second question?
Thank you.
The patient has, Dr. Peltier, the patient has told that when she feels like tired, she feels like all her body like vibrating, you know, like, and that's the question about what is this because and how to avoid or improve this sense.
Yes, so it's very common. Sometimes people have, with the nerves, they get this feeling of vibration. Some people from the drop in blood pressure, because amyloid affects the nerves that go to the blood vessels, and so the vessels dilate and all the blood pools, and then people feel like they can't stand up. And there's two ways to make that better. Or a couple of ways. One is medication. So you may prescribe, your doctor might prescribe medicines like mitidrin or doxydopa or other medicines that raise your blood pressure. And then what you can do is to avoid standing for long periods of time. So sit down or lie down if you're feeling those symptoms. Because if you keep standing, then you will pass out, and that would be bad.
Thank you.
There's another question there.
Buongiorno, chiedo scusa se parlo in italiano, ma non sono molto preparata sull'inglese. Mi chiamo Vincenza Bianchi, sono una paziente e volevo chiedere sempre al cardiologo qualcosa inerente alla possibilità sull'attività di fare attività fisica. Ho problemi di amiloidosi con deposito cardiaco, ma a tutt'oggi non ho gravi conseguenze, gravi limitazioni. Pratico ciclismo a livello amatoriale e monitoro i battiti durante la mia attività, che viene svolta a circa 120 battiti medi per una distanza di 40-50 km, quindi 2-3 ore perché vado piano, con punte di 145 massime quando affronto piccole salite. Volevo sapere se questi 120 battiti possono essere considerati normali o se devo usare qualche precauzione aggiuntiva. Grazie.
Le spiace se rispondo in inglese?
Assolutamente okay. No.
I think that's very good. If I do the same thing, I will go to 150, and I don't think I can stand myself 3 hours by bicycle. So it's very good. There is no worry whatsoever. I mean, it's something that if you feel good in doing this, there is no contraindication from cardiac disease in general and amyloid deposition in the specific topic of today. talking about this, there is a range of impairment of the cardiac function from very mild to very severe. If I am in the mild situation and I can afford this activity, that's completely fine, and I would say that's good, because it will help the cardiovascular system to be much more compliant, much more able to get in a proper fitness and to improve. No problem whatsoever. The only thing I would recommend is if you feel that there is a change, because heart rate is higher than previously, because you feel much more tired than previously, this should just put an alert to see, is this something changing? Maybe my rhythm is changing, maybe my drug therapy is changing. But apart from that, go ahead with no problem.
Grazie.
Prego.
We would like to extend a very warm thank you to all of our presenters this morning. We are aware that we have gone slightly over time, so the coffee break will be extended by 10 minutes until 10:40. We definitely don't want anybody leaving that has a question that's not been answered. So if you do want to write questions onto a piece of paper, we will make sure that they are answered for you here today. We don't want anybody going away thinking, I had a question I wish I had time to ask. You have your notebooks, papers, or contact one of us. Enjoy your coffee. Thank you for your participation.
She has a degree in neurology. She also has a degree in biochemistry and molecular biology, which is really complementary. She has a very long experience taking care of patients and making research on amyloidosis. And today, she will talk about emerging strategy to improve fatigue and pain management. Welcome, Professor Planté.
Okay, thank you very much for a nice introduction and the invitation in this amazing place. It's a great pleasure. So I will try to cover this difficult topic, emerging strategy to improve fatigue and pain management, and will give you some of my experience and my view on the topic. Here are my disclosures. So, well, we know that fatigue and pain are common manifestations in the setting of hereditary TTR amyloidosis. And according to this theory from Yarla some years ago, we can see that bodily pain and vitality, which is an indirect reflect of fatigue, impact significantly and heavily the quality of life of patients with TRANSTHYRETIN amyloidosis as compared to age and sex match general population. Well, really, what is at first fatigue? I think it's really important to realize the different components of these complaints. Well, it can be defined by a constant lack of energy, so it's a permanent symptom, and much more than a transient tiredness, for instance. In fact, in ATTR hereditary TTR amyloidosis, there are many manifestations and other causes resulting in fatigue. Of course, you have at first the neuropathy, the different component of the neuropathy, the sensory component of the neuropathy when you are dizzy, ataxia, but also, of course, pains that trigger fatigue, but also the motor deficit, and of course, autonomic manifestations, which are an important component of fatigue, mainly through orthostatic hypotension, but also through gastrointestinal manifestation we have heard of, triggering eventually weight loss. Cardiac manifestations are also an important contributor to fatigue, mainly through heart failure, and you can have other organ involvement, for instance, renal insufficiency, also trigger fatigue. And on the top of all those manifestations, you have, of course, the psychological impact of the disease, with anxiety, depression, and sleep disturbances, which are heavily impact also the disease and trigger fatigue. And because also we need to treat all these symptoms with multiple medication, combined medication, well, these also have often a side effect, fatigue. So all these contribute to fatigue, and I think it's really important to realize all this fair and to treat step by step all these problems. Neuropathic pains, well, we have heard a little bit this morning about neuropathic pains, but I think it's also important to really have the characteristic of these manifestation. Well, about 60 to 70% of patients experience neuropathic pain, both in early, late onset cases. It may be the first manifestation. Their characteristics, they are symmetrical, they are more in the lower limbs, distally in the feet, and then ascending progressively, and then they reach the upper limbs, and particularly the hands. Their other characteristic is they are triggered or increased by activity or efforts, meaning they are more present in the second part of the day, the afternoon, the evening, or even at night, impacting with the sleep. Well, as illustrated on this series from a recent survey, in fact, there is a broad spectrum of complaints through neuropathic pains. You have, on the one hand, spontaneous pain, paroxysmal or permanent, paroxysmal like pins and needle, paroxysmal pain, tingling paresthesia, but you have also permanent spontaneous pain, stabbing pain, pressure pain, which are all along the day. And these are important to characterize. Then you have evoked pain, which are pains triggered by stimulus like cold allodynia, pressure allodynia. So it's also important to recognize them because the way to treat them is not the same. You have, in this case, to try to avoid them. Well, of course, you have to differentiate those pains from pains in other organs, like gastrointestinal pains, like mechanical pain, pain from skin lesion, and so on. Well, so what are the strategies to manage pains and fatigue? Well, I'm afraid that we have to keep in mind this classical way to treat them, and I think it's really important to get all these steps. At first, to evaluate and characterize carefully this symptom, the time of the day when they are present, all the components of the fatigue, and then at first you will have to address the problem with a combination of drugs and non-pharmacological measures, particularly in the fatigue and the autonomic manifestation, for instance. And then you will have other approaches that I will address in a few minutes at the end of the talk. The drug treatment for neuropathic pains, well, here are the recommendations of the International Society Expert Panel Guidelines. This was published this year. So you have a strategy in the treatment, in the drug use for neuropathic pain. As first line with strong evidence of efficacy for neuropathic pain, you have the gabapentinoid treatment, gabapentin, pregabalin, or other treatment like serotonin reuptake inhibitor, duloxetine, venlafaxine, which are also antidepressant drugs. But please note that for all these drugs, one of the side effects can be sedation, can be dizziness, can be fatigue. So one has really to get a balance when using them where there is an association of fatigue. Then you have the second line treatment, so with moderate to weak evidence, opioid, mainly the tramadol, with also some sedation as possible side effects. They might be combined to the first line treatment very usefully. Then you have tricyclic antidepressant, amitriptyline with anticholinergic side effects. It can increase orthostatic hypotension, for instance. And when you have focal pain, please think about topical agents. These are based on lidocaine, capsaicin, and they might be very useful in combination to these first line treatment, or even in combination with tramadol. And then we have the third line treatment with weak evidence for efficiency in neuropathic pain. namely morphine, oxycodone, so the strong opioid, with also as side effect sedation, so they can increase fatigue, and also virtually in all cases dependence on the long term. So we try to avoid them on the long term. Then what is the management of fatigue? Well, the management of fatigue is again to evaluate and treat each of the components, whereas we review the components. And so you need a multidisciplinary approach. You need an expert neurologist to really assess and try to alleviate each component of the neuropathy, the sensory deficit, the motor deficit, and the pain, and the autonomic manifestation, each of the components of the autonomic manifestation. You need a cardiologist to assess the treatment at the best, particularly of cardiac insufficiency, because also cardiologists often use drugs that lower blood pressure. This can in itself increase fatigue, increase potential orthostatic hypotension. You need a gastroenterologist in your network to improve at the best the gastrointestinal manifestations that really trigger fatigue. And you need a psychologist or a psychiatrist to adjust the treatment for depression, anxiety that can also increase fatigue. Also, the first line approach will be pharmacological and non-pharmacological approaches. For instance, in the orthostatic hypotension, you have at first to review all the combination of treatment, because in all the combination of treatment, you are often drugs like diuretics, like anticholinergic drug, amitriptyline, and so on, that can trigger or increase orthostatic hypotension. So you have really to review first the different treatments and the comorbidity. You can get permanent diarrhea that in itself increase orthostatic hypotension. So it's really a step-by-step, process. And so it's so important to take into consideration comorbidities, medication, side effects, and interaction between them, between the medication and between also the comorbidities. It can be difficult, and I think it's important to take time at each clinic to review each symptom, the neuropathic pains, but each symptom of the autonomic neuropathy or other symptoms that trigger fatigue, to see if you really well adjust the treatment. And you have also to adapt, because this can evolve. Well, what are now the non-drug options, other non-drug options? Well, you have many various approaches. All of them are add-on treatment. Please keep this in mind. They are mainly exploratory so far, but they can help. They might be of some beneficial effect. You have to expect a mild to moderate effect, but you have to adjust them to yourself, to your own symptoms. At first, we have physiotherapy and physical therapies. I don't go into details. We have heard this morning quite a lot about this therapy. I think these are very important, but as we have heard, we have to adjust to each patient and to each manifestation, to each stage of the disease. So each patient has to really adapt to its own problem. Physical therapies might help in some cases, both for fatigue and for pain, heat, cold application, massage, fluidotherapy. Exercise training combined with psychological therapy, relaxation breathing technique. Again, I am not going to go in details. We will hear about some of this technique. We will hear about the benefit of yoga, I think, in the next session. So, of course, again, you have to adjust, but they might be of benefits, but you have to adjust them to your own problems. Then what about cannabis-based medicine? Well, this is a question that we have often from patients coming in the clinic. Hello, doctor. Can I use some cannabis for my pain? Can I use some cannabis to alleviate my fatigue? Well, I think it's an important question, interesting question, but we have not the proper answer. We know that cannabis can be herbal, plant-derived, or synthetic products, and they have not the same access across country. You have country even in Europe where you have free access, and other countries where it's fully illegal, like in France, so far. And I think their use is quite controversial. I think it's quite important to keep in mind that their efficacy is not yet established. So on the long term, I would not recommend the use of such medicine right now, because also it can trigger some dependency and some addiction. But it might be transiently of help. Neuromodulation techniques, these are more recent techniques that I would like just to expand a few minutes on the benefits that you might expect. Well, neuromodulation techniques are developed since, you know, the 19th century. They are based on the principle of electric stimulation applied to the different parts of the nervous system. So in other words, you induce electric current in the different parts of the nervous system. Well, it was obviously originally applied to brain, and you have a large spectrum of neuromodulation technique. Some of them are very invasive, and you have two of them which are not invasive and which have been studied in the field of peripheral nerve, namely the brain TDCS, transcranial direct current stimulation, and also the transcranial magnetic stimulation. I just illustrate this device. So as illustrated, they are not invasive. In the TDCS, you have anode and cathode, which are inserted within a cap that you wear on your head. And for the RTMS, you have repeated transmagnetic stimulation transmitted through coil, and you can get different type of coil. And these are sessions between 20 minutes to 60 minutes. Well, for the TMS, you have a continuous neuronal stimulation. For the TDCS, you have direct continuous electrical stimulation at low intensity. Well, you can get other modulation. I will just mention them in a minute on spinal cord, on peripheral nerve, and transcutaneous electric nerve stimulation, which are more widely available. Well, the effect of these neuromodulation techniques is not fully understood. So I think it's important also to keep in mind. When it's addressing the brain, it's acting through cortical reorganization, neurovascular regulation. But generally speaking, they modulate the pain neural circuit. And so, in fact, they act, in other words, in sort of masquerading, in fact, the pain symptoms. Well, as illustrated, the brain's non-invasive stimulation are applied to many kinds of central nervous disorders, stroke, Parkinsonism, multiple sclerosis. It was widely studied in fatigue for multiple sclerosis, but also in some psychiatric disorders, depression, anxiety, schizophrenia. It has been more recently addressed in neuropathic pain. So there are still limited application. These are works in chronic neuropathic pain, mainly diabetic neuropathy. I'm not aware of any works specifically in transthyretin amyloid neuropathy. There are also work in the field of nerve repairs. So right now there are recommendations for RTMS, mainly targeting the primary motor area, the M1 area, in chronic neuropathic pains. But we have to realize that we have a lack of long-term data on efficacy, safety, few control trials, so it's low level of evidence, and it can be a third-line treatment. Then one can have all the other neuromodulation technique. I just give you a kind of spectrum. You can get spinal cord stimulation techniques. These are more invasive approach because you have to implant neuromodulation device in the meninge, in the dure-mer, and it's more invasive. Well, it has been studied in intractable chronic pain, but again with very few evidence in chronic painful neuropathy, and so further work is certainly needed. Peripheral nerve neuromodulation, you have many different devices. You have some invasive approaches. I will not go
Sorry, Professor. We need to conclude.
Yeah, you have magnetic peripheral nerve stimulation, which is a less invasive technique with device temporary and then implantable. And you have now FDA approval for focal refractory peripheral pain in the field of post-traumatic, post-surgical pain or amputation after pain after limb amputation. So it might be promising, but again, we need further studies in the indication of chronic neuropathic pain in the field of diabetic neuropathy or amyloid neuropathy. Transcutaneous electric nerve stimulation. This is my last issue. This device is commercially available, widely available. You can apply it through the skin, so it's mainly for focal pain. And you have different protocols, but it's generally at low intensity, high frequency. And it has been now approved for symptomatic relief of neuropathic pain or musculoskeletal pain. Of course, there are drawbacks. They are efficient mainly during the time of stimulation, not beyond, and they are mainly efficient for local pain. Well, here are some take-home messages. I think we have still to address the problem of fatigue and pain with classical method, well characterize the symptoms, address with drug, with a stepwise process, non-pharmacological process, and the new emerging technique needs still further study, except maybe the TENS, but of course relaxation technique and all these techniques are of help and might be of benefit. Thank you very much for attention.
Thank you very much for this interesting presentation. And it's my pleasure to introduce you the next speaker, Martina Smorti. She's a professor in the developmental psychologist at the University of Pisa in Italy. And she has a broad experience in the psychological impact of the disease. And she's a really leading expert in this field. And today she will talk to us about this complex disease, how it affects the quality of life of the patients. So thank you, Martina.
Thank you, Roberta, and thank you to the organization. I'm very glad to be here, and yes. One moment, okay. Yes, I'm going to speak to you about the burden of disease for patients with amyloidosis. We have heard extensively how the amyloidosis impacts on physical health in terms of symptoms such as dyspnea, fatigue, and other symptoms that can affect the ability to perform physical activities. Other symptoms can affect the sexual life, with a repercussion also on couple life. All these symptoms can impact functioning if they prevent the patient from carrying out the daily activities and maintaining autonomy. And all these aspect has an impact on mental health, with an increase of anxiety and depression symptoms, and with the reduced quality of life for patient. Moreover, patient with amyloidosis reports that also with the ongoing of symptoms, also the relationship with caregiver can be affected. And in fact, caregiver itself can report a high level of distress associated with the illness. Caregiver participate in the suffering of affecting member, and can report also anxiety and depression related to the physical and psychological discomfort of patient. The patient may report his discomfort to the caregiver, and the discomfort can increase the anxiety and concern of caregiver. And with the symptom ongoing, and with the loss of autonomy with the loss of functionality of patient, also the request, the need for help by caregiver enhance, and so the request from patient to caregiver can increase, with an increase also of difficulty from caregiver to support the patient. And this can increase also the conflict with the patient. The caregiver who is not able to help the patient as the patient would like can be particularly stressed. And we know that caregivers are mainly female, partner or daughter of the patient, and so they are also involved in multiple roles, both working role and family role and other caregiving roles. So the psychological burden is very, very high for caregiver. Patient and caregiver, however, are not alone in facing with the disease, but they often are together in medical visit where they discuss about physician, and physician can explain them the disease, the possible treatment option, and the shared decision making. It is important in the idea that doctors take into account the preference, beliefs, and values of the patients. The involvement of patient and also caregiver in the decision making seems important, also because caregiver is actively involved in the care of patient. He accompanies the visit, he or her or she support the patient in the therapy management. But when we talk about shared decision making, we refer to three characteristics. So, a clear communication from doctor on the risk and benefit of intervention and alternatives, including also no intervention, the clinical competence that adapts evidence to individual patient, and the third, include the values, goals, and preference, patient expectation in the decision making process. Literature suggests that doctors with a better awareness of patient expectations are more able to meet the patient wishes and needs and to initiate an open discussion about unrealistic expectation, also leading to a more productive negotiation. However, literature also suggests that there are some discrepancies between the patient expectation and doctor's expectation about life expectancy and about prognosis, with patient reporting a longer life expectancy and a better prognosis than those reported by doctors. So it suggests that this topic is not well discussed among these figures. There are not so many information about therapy expectation, but this seems to be a relevant topic because we have discussed about the impact of physical symptoms, so the relevance of to efficaciously address physical symptoms, and so taking into account the preference and expectation of patient seems to be very relevant. On the other hand, the importance attributed by doctors to therapy endpoints guides therapeutic choice, and so we can answer which are the expectations of patient, caregivers, doctors, and institutional decision makers, and which endpoints are prioritized in choosing therapy. To answer to these questions, we conducted a research, cross-sectional research on amyloidosis referral center at Careggio University Hospital. And we would like to understand, among the effect of therapy for amyloidosis, how the reduction of mortality, the reduction of hospitalization, the reduction of cardiac symptoms, the preservation of autonomy and avoidance of the increased diuretic therapy were rated from patient, from caregivers, from cardiologists of amyloidosis center, and from institutional decision makers. If there are any differences among the rating of this aspect, and the third question is which endpoints are prioritized by patient, caregiver, cardiologist, and the institutional decision makers. We developed a self-report questionnaire that asks responders to rate the importance of the effect of therapy for amyloidosis from a Likert scale from 1, not important at all, to 5, extremely important, and responders should attributed a score to the below aspect. And the second question was to rank the effect of therapy for amyloidosis in order of importance. So the first is most important, the fifth is less important. We distributed the questionnaire to 166 participants, 64 patients, 56 caregivers, cardiologists, and institutional decision makers, and we showed that a reduction for mortalities and reduction hospitalization, patient and caregiver are aligned in attributing the greatest importance, about 5, while physician and institutional decision maker less important, about 4. The same for reduction of symptom and preservation of autonomy, with patient and caregiver attributing the highest score, 5, and physician and institutional decision making about 4. The same for avoidance of increased diuretic therapy, with patient and caregiver about the highest score, and physician and institutional decision maker about 3.5. But the second question, so it seems that there are differences. The patient and caregiver are aligned, and the physician and decision makers are aligned. But when we ask how do you rank the endpoint of therapy effect for amyloidosis, what we can see is that patient and caregiver, you can say every column is, the first is patient, caregiver, cardiologist, and the fourth is decision makers, and the color represent the ranking of importance. So for patient and caregiver, the first point, the first level is attributed to reduce mortality, and also for institutional decision makers, while for cardiologists the priority was to reduce admission in hospital, then reduce mortality, then reduce the physical symptom, preserving autonomy, and the last diuretic. For patient and caregiver, the first point for importance is reducing mortality, then to preserving autonomy, then to reducing admission, hospital admission, preserving, reducing symptoms, and then to the diuretic. So this data suggests that there is not the same opinion, the same importance attributed by patient, caregiver, and cardiologist to the endpoint of therapy. And it suggests the relevance to discuss therapy expectation with patient and caregiver, and also to evaluate the therapeutic choice, taking into account the patient expectation and also the caregiver expectation. It could be also relevant to discuss about which is the most important endpoint, also to avoid and resolve some unrealistic expectation that can emerge from a patient or from a caregiver, and also to encourage the acceptance in the disease or the acceptance of the treatment journey. Thank you for your attention.
Thank you very much for this very interesting presentation. And now I would like to welcome Stephen Mopu. Stephen is a nurse since 2011. Since 2018, he is playing the role of coordinating nurse at the National Reference Center for Cardiac Amyloidosis in Créteil, close to Paris, which is managed by Professor Thibaut Damy, present in the room. And the feedback on Stephen's work is really great and unique in France. And I think we should think about cloning him to have a Stephen available in the main city hospital in France. Welcome, Stephen.
Thank you very much. So, first, hello everyone, and thank you for your invitation. Before my speech, I must apologize. First to the English speaker in the conference room and the translator, because I think I will give you quite a lot of work today. English is not my language. Second, to all of you, because I cannot give a universal answer to how to manage multidisciplinary appointment. It depends on your country, your hospital, your illness, your amyloidosis. But I will try to explain what we have done in Créteil at Henri Mondor in France. It's not a perfect recipe, but it is our experience, and maybe it can inspire ideas for the others. As we have already... Yes, sorry. As we have already seen this morning, and as we will continue to see over those 2 days, amyloidosis is a multisystemic disease. That means it can affect different organs, but not always in the same way. Each patient is therefore unique in their illness, in their amyloidosis. This multisystemic aspect leads to several problems. The most frequent one is diagnosis delay. When the disease is not well known, it is difficult to make connection between digestive problem, carpal tunnel syndrome, and shortness of breath. Another difficulty comes from the healthcare system itself, where each doctor is very specialized. Communication between professionals can be complicated, and sometimes it is hard to step back and look at the patient as a whole. That is why the question arises, how can we manage multidisciplinary appointments? So, the answer to Mondor is, at Mondor before 2010, cardiologists did not know much about amyloidosis. Thanks to the initiative of Professor Planté-Bordeneuve, cardiologists at Mondor, including Professor Damy, just to name one, became more and more interested. In 2010, they created a care network that brought together several specialists who was aware about amyloidosis. In 2016, the network became a reference center for cardiac amyloidosis. And then it expanded nationally. Why I'm telling you this? Because organizing different appointments and being able to send patients quickly to the right specialist is a real teamwork. The patient is surrounded by a wide variety of professionals to ensure that the best possible care. The National Reference Center for Cardiac Amyloidosis is the core of a world network of specialists and tools, all working to improve patient quality of life. At the heart of the reference center, there is a full paramedical team, a secretary, psychologist, social worker, genetic counselor, dietitian, and also an art therapist, an étoile, who bring comfort, joy, and emotional support to patients. Finally, there are 2 coordinators, one care pathway coordinators and myself, nurse coordinator, specialized in amyloidosis. I will now try to present some of our mission. The role of the coordinators at the center is first to organize patient appointments, whether for diagnosis or for cardiologic follow-up, but also help to manage the first consultation in neurology, gastroenterology, or nephrology, or what else. We refer the patients towards the right medical or paramedical specialist, either within the network at hospital or in the city. And finally, we also have a role in informing and educating the patients, the most important, I think. Information must be provided at every stage of the care way. This can be at the pre-diagnostic stage, from the very first phone call, or during nurse consultation, before medical appointments. It also continues after diagnosis, with therapeutic sessions for patients and the caregiver, and throughout the journey, the pathway, during consultation, hospitalization, and during the diagnostic announcement, and after this, with the consultation of nurse. The better the patient understands their disease, the easier is it to treat them, because they can describe their symptoms more clearly. This is why you are here, I think. There is therefore a double benefit for both the patients and the healthcare team. So, the first appointment within the network brings together all the examinations needed for diagnosis in cardiology, either during a consultation or during hospitalization. We often organize the first appointment in 2 stages, so that on the day of the consultation, the cardiologist already has all the necessary results to the diagnosis, especially immunology tests and biopsy results, which takes time in modern. The more referring doctors know about amyloidosis, the more precise their reports are. This helps us anticipate which additional tests may be needed at the first appointment, such as an electromyography. In cardiology, it's not usually. This is why scientists' congress are so important. And here it's really great. We have patients, doctor, it's perfect. As I mentioned earlier, during this appointment, the patient and their family receive as much information as possible about the disease and the health status. Just as importantly, these visits allow doctors to get, with the help of symptom worksheets, a complete overview of the patient's involvement, neurological, cardiologic, digestive, and so on. When we talk about disease involvement, we must also mention amyloaffect questionnaire, which is systematically sent to a patient for their first appointment and follow-up visits. This questionnaire complements the symptom worksheet by giving a more precise picture of the intensity of involvement and its impact on the daily life. I just discovered the World Heart Foundation forms, and it's quite the same. It's really great, I think. Maybe we will copy. It is quite long, but it's allowed for complete evaluation and understanding for the patient different symptoms. If you want it, you can find the questionnaire on our website. Having a better understanding of the patient condition is good, but it's only useful if you can act on it. That's why it is so important to bring specialists together, to obtain quick opinions, or to organize specialized appointments, easier with the network. This specialized, as I already mentioned, may be doctor, but also paramedic, such as psychologist, dietitian, clinical research assistant, physiotherapist, and another nurse coordination.
I'm sorry we are late, if you could speed up a bit.
Oh. Okay, you can ask question after. Just in the same idea of information, the Cardiologist Amyloidosis Referral Center developed training program for paramedical staff and medical staff in order to improve patient care by strengthening their skill. At the same occasion, we share our experience and our way of working with as many people as possible. The first session for paramedical is planned for early October, and we hope it will help further improve patient care. The more knowledge we share, the better care becomes. It is always valuable to see what is being done elsewhere, not to judge, but to learn and progress. So to conclude, and to try to answer the starting question, we all need to work together, patient, paramedical staff, caregiver, doctors, and also our therapists. Together, I think we are stronger, and that's why we are here. So thank you for your attention.
Thank you very much for this presentation. We are late, but we will take some questions.
While we're waiting, just one word I believe can reassume this session: communication. So please communicate among physicians, with your physicians, inside the family. If we don't know what you want and what you need, we cannot give you what you want and what you need. And on our side, we really need to listen to what you're saying. So please.
No question? I'm sure you have. Don't be shy. I'm sure you have some.
Well, okay. There's a question there. Oui. You can speak French.
Oui.
It will be translated.
Si vous voulez bien traduire, je vous remercie. Je remercie l'approche multidisciplinaire telle qu'elle a pu être exposée. Moi-même, j'ai appris à travers vous que j'avais des comorbidités telles que le syndrome du canal carpien pour lequel j'ai été opéré et également la réduction du canal rachidien pour lequel j'ai été opéré, voilà, 5 à 7 ans. Quand j'en ai parlé a posteriori à un cardiologue, à mon cardiologue, et ensuite au rhumatologue, l'un et l'autre ont été surpris par cette corrélation entre l'amylose que je connais aujourd'hui et les précurseurs. Et j'avais posé la question à Marseille au professeur Habib. Il m'a dit que le rhumatologue aurait dû faire analyser ce qu'il appelle le matériel. Et à ce moment-là, on aurait pu peut-être établir, il y a 5 ou 7 ans, une corrélation entre ces comorbidités et le résultat actuel de l'amylose.
C'est en fait un témoignage. Est-ce qu'il y a une question derrière? Quelle réponse en fait vous avez fait un témoignage, mais est-ce que vous avez une question qui...
Oui, pourquoi s'il n'y a pas plus de coordination aujourd'hui entre ces différentes disciplines, que ce soit quand je vois l'implication multidisciplinaire autour de l'être humain à travers le centre qu'est l'amylose, je suis étonné. Et pourquoi s'il n'y aurait pas plus une formation dans un secteur de l'hôpital, c'est certainement plus facile de disposer de l'ensemble de l'équipe, mais pour les professions libérales isolées, c'est peut-être plus difficile prendre connaissance de cette maladie qui représente plusieurs disciplines médicales.
Merci beaucoup pour cette question. So I will try to translate.
I think maybe Professor Dami is trying to answer your question.
Maybe I do a quick translation. So this is a patient asking the question, talking about his own experience with cardiac amyloidosis, and he suffers for canal Carpian syndrome and also some issue in the back operation, and he's asking why there is such a poor coordination between the discipline when we have amyloidosis.
So if I can try to reply to our French patients. So I don't know if I need to speak in French or in English. Or I don't speak Italian. French?
English? As you want.
Yes. So you are totally right. There is a lot of work to do to inform rheumatologists, orthopedists. And you can't imagine the energy that we spent with cardiologist colleagues to train cardiologists at first. And you can imagine how what we've done in France. It's totally amazing regarding the cardiologist informations. So we really now want to focus on rheumatologists and orthopedists. And so next year, we will run a campaign on informing a national campaigns to try to reach rheumatologists and orthopedists through their society. And we will do a public campaigns. But for that, you will need your help of the patients' organizations. We need also the pharmaceutical companies to get the money to run this campaign. And we will do in France a national screening, okay, in 32 hospitals to get these patients with rheumatologic symptoms or history of surgery, etc., to get screened for cardiac involvement. And it's called the Chameleon campaign. Chameleons means, of course, different colors, different signs, and we need your help. Thank you. But I think it's everywhere the same things. Connecting people and teaching about the disease, and there is 6,000 rare diseases. So how all these people can be informed as well. But we need to work together, and I'm sure that we are doing that. Thank you.
Thank you very much, Professor Dami. I think we have time for just one more question, if the audience wants to ask one question. There's one in the first line, prima riga.
Just a remark, I think that bringing together 4 doctors from different disciplines is something completely utopic. I never saw these 4 people have enough time to come together and treat one patient. It's nice to hear, but it never happens.
Maybe Professor Dami also, you could...
Well, I can give you the Italian experience on that. In Pavia, we have a center dedicated to this disease. And of course, there is a physician that's responsible in first place for the patient, but then there are all the other specialists involved, and the cardiologist is directly dedicated on site to the patient, and then the psychologist, and we have dedicated figures in the hospital that we can reach and talk and send the patient to in order to have this holistic approach and really multidisciplinary approach. It's not easy. It has been built before I got there, of course. It's a long history, but we try to make it work. And we have seen the importance of that for the patients.
And just, I would like to bring some hope. But when you are speaking with rheumatologists and orthopedists, they are so happy that when you explain that they can save a life by getting a diagnosis done, you know, they are just dealing with pain, with etc. And they are very happy to get involved. But it's true that we need to better communicate using the society of each specialty, but I'm sure that it's going to work, really. So, of course, we need connections to make connections, and you have also the power as patients to inform your doctors. So in France, we developed leaflets for rheumatologists, orthopedists. Everything is accessible on our website. Because patients, you have to teach to your doctors what is amyloidosis. And you have the power to do that. Go back to your rheumatologist, go back to your orthopedic surgeons, and make what happened to you, and what will be your different trajectory if you have been diagnosed before. So you have to do also things. You can't count only on our energy and times, because we don't have a lot of time, a lot of energy, but you need you. Okay, thank you.
Maybe a last question.
It's not a question, I would just, to corroborate what Thibaut Damy said. I must say, when I came to Créteil more than 10 years ago, I think the cardiologists were not aware of the disease. So let's see now, I mean, the room and the doctor room is full of cardiologists across the world. So I think it will be the same for the other specialties, the orthopedists, the rheumatologists, and so on, but it takes time. But believe Thibaut Damy, I think it's a challenge, but we have to inform more. Still, it's a hard condition, so it's difficult to diffuse the information, but it will go on, I think. Thank you.
Thank you. One question there. Please raise your hand.
Merci. Bonjour, je me présente Monsieur Vanny Bertrand. Je suis atteint d'amylose depuis 2 ans, détecté depuis 2 ans. Je suis français. Lorsque mon cardiologue m'a annoncé qu'il avait un tout petit doute sur mon amylose, j'ai bien été content de le trouver, car tout de suite derrière s'est engagé un processus qui a permis de détecter et de confirmer l'amylose. Ensuite, ce qu'il faut savoir, c'est qu'en tant que patient, j'étais heureux d'aller sur Internet et de trouver un réseau qui s'appelait Réseau Amylose. Alors le professeur Damien ne me connaît pas, mais moi je le connais parfaitement, j'ai vu tous ses tutos, et ensuite j'ai pu voir de nombreux intervenants, notamment vous également sur un tuto, et j'avoue que mon cardiologue a été tout à fait ravi de savoir que ça existait, et maintenant on discute avec lui, pas d'égal à égal, mais quand je lui dis j'ai mal là, il prend en considération et il me croit. Voilà, c'était tout. C'était pas une question, c'était un témoignage.
Merci beaucoup.
Merci.
So here is a testimony of a patient having cardiac amyloidosis who knowing very well the reference center of Professor Thibaut Damy, and who is following the network developed on that, Réseau Amylose, and he's very happy with all the aid he had through that. Thank you.
Thank you. One last question or comment?
Volevo chiedere se c'è una relazione fra artrite reumatoide e amyloidosi wild type, e se ci sono sintomi che si possono confondere.
So I'm going to translate very quickly. If there is a correlation between amyloidosis, wild type amyloidosis, and rheumatoid arthritis, if there are symptoms that can overlap. And I'll comment on that if you wish. Well, the correlation is not well documented, but for sure some of the symptoms are common on the two diseases. So also for the hereditary form, not only the wild type. So definitely there is a difficulty in doing the right diagnosis, because some symptoms, the pain, the swallowing, are really similar. And so this is one other field in which the rheumatologist and the expert in amyloids really need to talk to each other, because in some moments we need to decide what is better for the patient, what type of treatment, and then sometimes also trying the treatment like cortisone, for example, can write the diagnosis in this difficult field. But definitely it's easy to see some overlap in these two diseases. So also in this case, communication.
So it's now time to close the second session. Thank you for your attention. And I would like to welcome the next chairman. So first of all, Catilina Bebeloni from the Baleares Patient Association and also member of the board of the Amyloidosis Alliance.
And it's my pleasure to introduce Pietro Guaraldi. He's a neurologist at the Amyloid Center in Bologna, so very, very expert in the field. And thank you again for the past session.
So thank you for the introduction, and welcome to section 3, which is focusing on the benefits of physical activities. We have already listened some talks on this early this morning, and definitely all of us agree that physical activity plays a crucial role in promoting well-being and quality of life, especially for patients living with some chronic condition. But yet in amyloidosis, exercise requires some specific consideration. So, because as you know, patient may present with neuropathy, patient may present with autonomic dysfunction, patient may present with restrictive cardiomyopathy, all of which can affect exercise tolerance and safety. So this is not only, physical activity is not only a hot topic, but it's not trivial, because we have to consider all these aspects, and the simple recommendation such as be more active is probably not enough. But as we've heard earlier, programs must be carefully adapted and tailored to each patient profile. And today we have the opportunity to discuss this topic with two long-standing experts, Alan Levy and Ines Limon, who will present us two different but complementary approaches.
Hi everyone, it's my pleasure to introduce the next speaker, Alan Levy. He is from the UK and is a strength trainer and nutritionist. Alan has over 10 years experience with amyloidosis patients and has collaborated with associations as UK Amyloidosis and New Zealand Amyloidosis Patient Organization. So welcome on the stage, Alan.
In the yoga. Did not share the presentation. Should we change the order of the presentation? What is the issue?
realised that they haven't had it on the computer, so they just put it.
Okay. Do
we
you think?
need to say something?
Do you think we can
Just say
change?
short. They're just dealing with it now, so they'll be just short intermittents. It's up to you on that one.
Sorry for the delay. We have some technical difficulties we're trying to manage now. Two minutes. We can take advantage of these few minutes. If you have any questions, again, we are happy to discuss, so don't be shy. There is no stupid question. All the questions are very relevant to us.
I'm going to bring the other person.
Yes.
Okay.
I'd like to call them to the...
Yeah.
Okay, we are going to introduce the next speaker. Okay, she is Inés Limón. She is from Spain and is a yoga, meditation, and mindfulness instructor. She also has extensive experience offering group yoga sessions to patients and family living with amyloidosis. She has collaborated with patient associations such as the Valverde del Camino in the south of Spain and the Balearic Amyloidosis Patient Association. Please, Inés, the stage is ready for you.
No, 15 minutes. And no, 15 minutes for the introduction, and then there is the practical yoga section. Yeah. So I think, at least, yeah, 15 minutes. Okay.
After I have more or nothing?
So, lunch. Where is the program?
I want to share you a practical of yoga, so I want to know the time.
So, yes. Because we have lunch at 12:30.
Good morning, everyone. Before starting, I would like to express my gratitude to the organization for giving me this opportunity to share my perspective about yoga in this commit for medicine issue. And thank you, Catilina, also to push me in this adventure. To also to to allow, I don't know how explain in English, to the hermanam, to the born, our association in Baleares and in Andalusia. So thank you for that. And thank you all for being here and allow me to give you the practice that I am going to share with you today. Now, let me begin with a question. How many times a day do you truly notice your breath? And even there to change its rhythm? Or have you ever taken the time to count how many breaths you take in a minute? Nothing, never. Interesting. This is the key to today's journey. I began asking myself this same question when I started working with ASBEA. ASBEA is an association based in Valverde del Camino, a small town in Huelva, Andalusia, near Portugal. This community has a focus on Andrade disease, a type of amyloidosis, and through them I discovered how powerful the connection between yoga, health, and breathing could be. It's curious because when I first heard about yoga, I thought it was a mostly discipline of beautiful postures and impossible stretching positions. But when I started to practice and I discovered that the yoga reaches a deeper dimension of health through the breath. I still remember when my yoga teacher, in the middle of the postures that I stop my breath, say, yoga is life. And if you don't breathe, it isn't yoga. So how true that was. Well, we are born with an inhalation and we die with an exhalation. And in between, there is a constant flow of inhalation and exhalation through which millions of experiences occur, experiences that shape the rhythm of our breathing. I'm going to step that. Also fascinating, a study from the University of Tokyo showed that people who exhale too quickly, like me now, had a higher predisposition to anxiety when facing difficult situations. And the magical thing is that the yogis already knew this and sharing this thousands of years ago. According to yogis, as the breath flows, the mind flows, because there is a feedback loop between the mind and our breath. As the breath calms, does the mind, and vice versa. This is exactly what we train at Asvea. The breathing of Andrea patients through the different conscious breathing techniques and movement to increase lung capacity and improve respiration. Every breath we take sends a message to our autonomic nervous system, which is responsible for whether we live life in an overly intense way or the contrary with serenity. People with Andrade disease go through many situations of uncertainty regarding diagnosis, tests, and treatments, often with intense sensation from the symptoms of the disease. Connecting the breath and training through the yoga is a tool to enhance serenity, even in the most difficult moments. In yoga, the breath is called pranayama. I don't know if you know this name. Is considered the bridge between physical body and the subtle body. We know subtle body, our invisible body. Each inhalation nourishes us. Each exhalation help us let go our tension. So before we begin to practice, let me explain a bit details about breathing and how it supports yoga practice, because I want to practice a little bit yoga without mistake or without pain or something like this. So we have 3 types of breath. I don't know if you know the different types of breath. We have the first one, the upper in our chest. If we can try if you want. If I take an inhalation, I feel my upper chest. Exhale. But we have another one where we have the coastal breath. If you have to take an inhalation, open your bean, the costillas. Breathe, thank you. Breathe. You can, and also you have to improve, to feel your diaphragm or your belly. This is the first one. So we're going to training with the different types of respiration, of breathing. In yoga practice, we have different phases. We have the first one is the different techniques of pranayamas, of breathing. Now we're going to practice samavriti. Samavriti is a technique just to inhalation in 4 times and exhalation in 4 times. I'm going to guide you with my finger. And we're going to start with that. Then, because how minutes I have?
Still
5 minutes.
10 minutes. 10 minutes.
Okay, perfect. Second phase, we have a movement. In this movement, I want to say you that if you notice some pain, you have to release the movement, but not rest your body. Try to search or looking for something that move your articulation and your musculature, okay? And we have another phase. I hope that we have time to do this, to relax, to connect with the breath after the exercise, and take a time to connect with this message that our body, that unconscious body, say to you in this point of your body. So, if you want to start, yes? Okay. So, I'm going to ask you if it's possible to open your arms. If you touch your neighbor, maybe you can move another chair. It's possible. Thank you. Perfect. Okay. I don't know for the recording if I sit in the middle of the stage is better for you, is good for you. I'm going to sit down in the middle of the stage without microphone. It's okay, no? Ah, okay. Perfect. So we can rest our back in the chair and rest here and eliminate whatever cross in your finger, on your leg, open your body. And if you feel comfortable, you can close your eyes or even take your gaze to the floor. So we're going to start with inhalation and exhale through your mouth. Again, inhale. Exhale through your mouth and relax your shoulders. Inhale. Exhale through your mouth. Relax your legs. Okay. Close your lips and start to breathe in with your nose, through your nose. Notice, how is your breathing now? How is your breath in this moment? Relax your forehead. Relax your tongue. And connect with this movement of your chest, coastal, and belly. Keep your eyes closed, and we're going to start sama breathing. First, inhale deeply. through your nose, exhale. Inhale, 1, 2, 3, 4. Exhale, 4, 3, 2, 1. Inhale, 1, 2, 3, 4. Exhale, 4, 3, 2, 1. Inhale. Exhale. One more. Inhale. Exhale. Keep your eyes closed. We're going to introduce a retention in our breath. Release the air. Inhale. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Exhale. 4, 3, 2, 1. Inhale. 1, 2, 3, 4. Hold. Exhale. 4, 3, 2, 1 more. Inhale. Hold. Exhale. Return to the natural breath. And start to move your fingers, your neck, your shoulders. And when you are ready, you can open your eyes. Well, this is the first step in a regular class of yoga in ASBEA Association. I have 3 minutes. Okay, so we can move something. So if you can go to the top of your chair, to the edge, no? I know. Edge. We're going to raise with our arms. So inhale, raise the arms. The 2 arms. Exhale, low. Inhale, up. Lateral hands. Exhale, open more and low. 3 more. Inhale. Exhale. Inhale, move up, and stay here to take the elbow. Here. From here, we're going to move our pelvis forward and raise our beam. I forget, our costillas, beam, our costal, ribs, our ribs, chest, ribs. And relax the shoulder blades. Yes? Here, inhale in the center, exhale to the right. Inhale, center, exhale, left. Again, inhale, the middle, exhale, a little bit more. Exactly. Inhale. Exhale. One more. last one. Exhale, very good. Inhale, go, move up your arms, and exhale, if you go up, down, and move your neck to say yes and no. Yes, very, very good. Release your back, your shoulder, and go move up vertebra by vertebra and stay again in your edge of chair. Well, I have the last exercise. The last. I have more exercise, but the last exercise. So I don't know if you can stand up and situate behind of the chair. You can? Or with, maybe the first, because we're going to do a balance exercise that if for our patient is the favorite exercise because it stimulates our blood flows on your toes and remove our energy in this place, and it's very important for the Andrade patients. So I'm going to put here, we're going to inhale and move up the heels and exhale down. Okay, very well. Inhale, move up, exhale, one more. Inhale, up, and stay here. Strong your legs, strong your belly, up your chest, and maybe you can stay here for 5 breaths, maybe 4, and try to move up your arms. Maybe the other one. Inhale. Exhale 2. Keep. Inhale. Exhale. Lower. Very good. Very good. Release the tension of your toes. So stand up. And I stand up. Sit down, please. Sit down. So I would love to finish this session, this short session, because we take more time to practice our breath, our movements, to take conscience about the impact of this method in our bodies. But I would like to do something that everybody far for the yoga thinks that is a crazy thing. But it's very important to relax our diaphragm. That is a chant, a mantra, Om. When you say Om, increase your vibration of your belly and release too much our respiratory musculature. So we're going to end with that. I'm going to say you inhale, and then we start to say Om, all of our exhalation. Yes? Let's practice. Inhale. Thank you very much for your patience with my language, and thank you very much for your collaboration with me.
Thanks, Ines, for this amazing presentation. Thank you.
So, thank you again, Ines. I just want to add a quick thought that these techniques that have been used by yogis for thousands of years actually have been proved scientifically effective. So this kind of exercise help us to maintain our heart rate variability, which is one of the first aspect that is affected by the condition. Patients with amyloidosis tend to lose their, we have heard this morning, their chronotropic ability, their ability to modulate heart rate. And these exercises are a very important training to restore this capacity for cardiovascular function. But we're running late, so again.
Alan Levy, please.
Second time lucky. Hope we had a nice bit of meditation to get over the technical difficulties there. Bonjour, buongiorno, guten tag, hello. That's the end of my foreign language speaking now, so it's over to the translators for the rest of it. I'm going to be discussing the benefits of strength training for amyloidosis patients. And one of the key aspects that I think we overlook is how difficult a lot of these training concepts are for people. A lot of people will be thinking to themselves, I just can't train. I have too much perhaps peripheral neuropathy, or maybe there's frailty, lack of balance, or just the concept of going to the gym seems overwhelming and too challenging. So what I endeavor to do today is completely counteract that perception and give you a workable solution that everybody can do today, starting now, that is absolutely doable and that is feasible. So, hopefully that passion of mine will translate, and we will go on to the next slide. So we've seen this picture many times today, so everybody's working from the same blueprint. The multifactorial aspects of amyloidosis and how they affect every aspect of a person's life. So I'm not going to dwell on the negative aspects today, because we've discussed them at length, and we know from cardiomyopathy to peripheral neuropathy, balance issues. What I'm aiming to do, hopefully, is give you some suggestions and some workable solutions that you can implement as of today. So I can dazzle you with a number of reasons why strength training is important. I'm a strength coach, of course I'm going to say that. But the point is that what we have here are developments and improvements of every system of the body, whether it's brain, muscle, movement, balanced blood sugar. So we're talking about things like insulin management, which is just a flashy way of saying that when you are training, glycogen and glucose has somewhere to be ushered and muscle cells to drive into, rather than just circulating in the body. So if anybody has, for example, type 2 diabetes, exercise, specifically strength training exercise, is very, very critical. The key thing is, whether it is improved bone density, improved neuronal efficiency, which is another flash way of just saying the speed or velocity of the signaling from the brain to the muscle, or whether it is, all the aspects around insulin management that I mentioned. The key thing that I can't emphasize enough is the most important. This will improve your quality of life. Okay, that is after all what everybody wants. So I can dazzle you with different protocols or all of these things. The key aspect that we're looking for is an improvement in your day-to-day activities in your life. Whether that is gardening, whether that is taking a stroll with your grandchildren or your children, whether that is doing shopping. Things that we take for granted as day-to-day activities for people with amyloidosis can present as real viable problems. And so strength training is a phenomenal way of counteracting that. So we have obviously improved blood pressure control, etc. Better quality of life. That's the key reason why you're all here. An interesting aspect that we've touched on is peripheral neuropathy. For those who follow Dr. Andrew Huberman online, he has a pet theory that the peripheral central nervous system sort of degenerates from the outside inwards. So the first points of contact where you start to lose sensation are the extremities. So they're the most distal portions from that center line. So there are protocols that we need to put in place to improve those aspects as well, and I'm going to touch on those. So so those of you who have amyloidosis, you'll be familiar with that glove and sock aspect. And the dexterity that you sometimes lack in your fingers, grasping things, opening a bottle top. These can all be, now I'm not saying, oh yeah, you can completely, you can cure these things, etc., but you can really reduce their impact, and you can, from the microphone, yeah. Right, sorry about that, yeah, it's a little bit, right, so basically, we're going to go over some of the aspects that you can train to prevent those sort of issues really becoming more and more detrimental, and working on the separate aspects of grip strength, because there are a lot of areas around that we need to touch on. So we've gone through this in terms of how strength training can help, maintaining independence, improving your mood, improved life satisfaction. It has a lot of mental health aspects because it improves dopamine function in the brain, can improve uptake of testosterone in the bloodstream. So you have all these benefits to strength training, all of which you will see very shortly can be attained in a very straightforward manner. So what I'm going to be talking about a lot today are the aspects of strength training that were culled from Soviet Russia. And hopefully it will revolutionize your own fitness, not in a overthrow the government and take over the state kind of way, but in a improve your health and lifestyle way. I don't want anybody getting the wrong idea. It's not that kind of meeting. Staying safe. I'm going to gloss over this because obviously a lot of you will be working with your healthcare providers. We touched on the cardiac aspects of training and how you don't want to overdo certain aspects of cardiovascular training and place too much intensity on it. This is something that when I've been training with my client Vince Nicholas, who I've trained with for 10 years now on strength training to really reduce the impact of amyloidosis in his life. We've really structured that as quite an important point of not overdoing cardiovascular training. So I think that just doing day-to-day activities, long, slow, steady state training and not really overdoing it is very, very important. Listening to your body, probably a good guideline would be not letting your heart rate get above 120 beats per minute, but then obviously everybody's different. Interval training, I've got a bit of an issue with because those little blocks of suddenly going from very, very sedentary to explosive movement could be detrimental. So I would veer on the safe side of things and just try and keep, the prolonged periods of training, maybe walking, etc., gardening, rather than, sudden explosive movements which could put too much emphasis on the heart. So move over that. So some of the considerations are dizziness. So when you are dealing with aspects of amyloidosis that can cause dizziness, falls, etc., strength training is going to be of benefit because certainly in the style of training that I talk about, you are deaccelerating under inertia. So if you're doing, for example, a very slow movement, what we call an eccentric movement, you're teaching the body to deaccelerate under inertia. So if you do trip or you do fall, you're going to actually be able to slow yourself down rather than just plummeting forward. So people who tend to trip and just fall lack that what we call that eccentric control. I'm going to gloss over if anybody, by the way, wants the slides for this presentation or a longer version of it, it is online on my YouTube channel. So if I'm going a bit too quickly for you and you want to go into a bit more detail, there's the whole presentation there and you can watch it at a bit more length. Or if you just need something to send you to sleep, that might work as well. So monitor your signs and symptoms. So for example, things like if you've got a Fitbit, heart rate variability is a very good measure of your recoverability, blood pressure issues. Listening to your body. Nobody will know your body better than you. So it's very, very important that you actually working on how you feel on individual days. Heart rate variability is a very good one because it will show you, sometimes you might think you're tired, but actually your recoverability is quite good and you can push through. So we're going to talk about how to adapt the exercises, but the cornerstone, because I just looked at the time and I realized I've got 5 minutes to get 20 years of strength training into 6 minutes 38. What we're going to do is we're going to talk about the fundamental movements that every strength training program should have and how to implement it. Okay, so I'm going to move along to the sexy part of it now. Obviously, you want your goals to be specific, measurable, attainable, relevant, and time-bound. So don't go by anybody else's goals or standards. If just going up and down the stairs 3 times is tiring you out, that is your specific measurer. You can say, right, I'm going to use that as my measurability standard, and I'm going to see how that will improve. Choose something that's measurable to you. I can't take 2 bags of shopping out of the boot of the car, but now I can. That's a measurable goal, and also it needs to be attainable. You don't want to make something that's unrealistic. It needs to be relevant to yourself, and also I'll give it a time frame. So say to yourself after today, do you know what? I'm going to listen to him. I'm going to indulge Alan on what he's saying. I'm going to give it a month, and I'm going to see how I improve. You know, give yourself a time frame, because when you just sort of keep things very abstract, they can tend to drag on and on. So you need to really have an idea of how long you want in order to achieve these things. As I said, all of this is in more detail on the YouTube channel, so if you want to go through it at length, and I will make myself available for questions afterwards if there's anything you feel that I've kind of skipped over or was unclear about. Okay, so this is important. I would take a photo of this slide because this will give you a solid foundation in, like I said, condensing all those years of strength training into a very short period of time. You have primary movement patterns. These are the key movements that everybody needs to utilize when they're training. So it is some sort of pull. Now that can be horizontal or vertical. You need to have a hinge movement. Some form of squat, so coming down as low as you can comfortably go. A pushing exercise, once again, that can be horizontal, but it can also be vertical. So you can see that it gets a little bit more complicated. A lunge, I highly recommend walking through customs like this. Because, interestingly enough, they cleared me very, very quickly. They were just like, let him through, let him through. So, you know, even if you only take that away from today, use that. And also, this is one I put in myself, which is carry, which is grip strength, okay? I'm going to touch on this very quickly. Grip strength is more than just, you know, holding onto a bag. You've got carry, which is obviously carrying, but then also you've got pinch grip, you've got crush grip, and you want to work on all these. So there are a lot of tools you can get online now. If you're in the UK, there's Gods of Grip, as the name suggests. They've got everything grip related. And I highly recommend using that. Even if you haven't got that sort of equipment, just loading up a heavy bag and walking around it, one arm at a time. So that's better for your spine and your core stability as well. So you want to use one bag rather than 2, because that can really put too much pressure on the spine. Okay. Now we're on to the 3 minutes. Russian strength training in 3 easy steps. You choose an exercise that you find is challenging, okay? So for example, say push-ups. Okay, so you say, well, I can do 8 push-ups and then I face plant. Okay, what you're going to do is you are going to take a tiny percentage of that, so you're going to take 3 repetitions. So everybody can do this. You're just working on your own ability. If you say, well, I can only do 5 push-ups, fine, do 2. But this is the key. You're going to use what's called the law of repeated endeavor. You're going to do it again and again and again through the day. 5 times. 5 times. How long break? 2 or 3 hours. You know, you take a phone call from Maggie. She's coming around. You're going to have coffee with Tom. You can spread this out through your day. It's infinitely doable. And it also means that what you can start to do is structure your training in a very effortless way. It doesn't become such an onerous task. And this will work for everybody, okay? Because strength is a skill, and a skill is learned through repetition. So the neurons that fire together, wire together. So this repeated endeavor is going to increase the neuronal efficiency, that speed from the brain to the muscle. I've tried it out myself just over the last month before I came here. I gained about 1 kilo of lean mass, lost some body fat, and the training, you know, my colleagues laugh when they see it. They're like, is that all you're going to do? Yeah, that's all I'm going to do. 3 chin-ups, take a break, answer some emails. So this is what I'm trying to get across. It doesn't have to be chin-ups. Everybody's thinking, well, I can't do that. But what I would also recommend is maybe pick 1 body part a day. Don't go too gung-ho. So I would say maybe Monday you do some squats. Tuesday you do push-ups. Because otherwise you're going to tax yourself too much. Listen to your body. Don't overdo it. And the beauty of this, and I wish I had more time because I've read a lot of research recently. My key hypothesis, certainly when I was training with Vincent, was that fundamentally we had an increase in negative byproducts in the body when you're training too long. Things like lactic acid, pyruvate, ammonia ions, all of this sort of stuff. It's like the gunk in your body and the smoke that's coming out of the body from extreme exercise. If you keep the repetitions low, you don't tap into that, okay? Because you're working on a different system. It's the creatine phosphate system and ATP. I'm not going to go into that today because that's another story for another day. But basically, you're not creating these negative I wouldn't call them toxins in the body, especially when amyloidosis is so inflammatory. You want to avoid that. So you're keeping the repetitions low, you're doing a lot of them. So you do multiple easy sets throughout the day, you focus on one exercise a day is what I would recommend. And remember, strength is through tension, not fatigue. So I would use resistance bands, for example, if you start to find the exercises are too easy, because they're quite forgiving on the joints. Another aspect that I've been working on very successfully with Vincent is what we call tempo. So I'll just demonstrate very quickly what that looks like. So if you're doing a squat here, the body's only got a very, very quick exposure of that, that tension on the body. However, it's very, very different if you're now going and really lowering yourself slowly. The muscles are under tension for a longer period then. So that's what I would recommend, is you can start to play around with that. If you're finding that the exercises are too easy, you can start to add things like tempo, and that will create more tension on the muscles, tendons, and ligaments, okay? Once again, all very, very safe approaches. Right, I've got 20 seconds, so. The keys to strength training, the Russian way. Focus on one exercise. Don't go too crazy with lots of different exercises. Flawless. Make sure your technique is beautiful, okay? We see all these things on The Biggest Loser. Oh, I can't do any more. And the PT shouting at them with a little whistle going, come on, you can do 8. That's not how we train. Vince would say that is not my approach at all. You don't go to fatigue and you're not doing that sort of thing. So what you're aiming for is just to keep the technique really nice, law of repeated endeavor. So repeat, doing the exercises. I'd say just 5 or 6 times. You don't have to go crazy. Stay fresh. You shouldn't be sore because the repetitions are so low and you're not producing that lactic acid. You shouldn't wake up the next morning and think, oh my God, I've really, I can't get off the loo now because my legs are killing me. And fluctuate what you're doing, because you want to keep changing things up. Once again, I'm really sorry, I haven't got time to go into all the details of that. So I'm hoping at another event or further down the line, I've got more of an opportunity to tell you how to fluctuate those exercises, because a lot of that is really delving into the weeds, and unfortunately we don't have time. So it's called Greasing the Groove. If you're interested in where this came from, the work of Verkhoshansky from the Soviet Union was really a pioneer in it. And then it went over to, I think, Pavel Satsulin, who is one of the coaches that I kind of follow for this sort of information. Put this through. And it's small portions in a spaced out interval. All of you will know from today that just sitting here, taking in information, sometimes it can be overwhelming. So when you consolidate it with little breaks in between, we remember it a lot better, don't we? So if I tell you something and then you've got a 20-minute break, you're much more likely to remember it than if you're just saturated with a lot of information. So it's small bite-sized chunks rather than cramming. Types of grip strength training, so you can see, you have all the different implements here. I would also recommend not just focusing on grip strength, you also want to focus on the extensor muscles, which are like elastic bands that go through the fingers and extending the fingers, because you always want to work agonist and antagonist. You don't want to just focus on one aspect too much. And you can get those Chinese balls, the little ones that make the tinkly sound, and that will work with your dexterity as well. There he is, Vince himself. I won't embarrass him by going through all these photos. I'm behind the camera laughing while I torture him. These are all, by the way, for those of you who are interested, and you might be thinking, oh, I really want to get more of these exercises and come to grips with them. If you go to my YouTube channel or the New Zealand Amyloidosis Patient Association page, there's a YouTube link, and it's got all these exercises in great detail where I explain what they're for, how to set them up, how many repetitions to do, how many times a day, what the purpose is. So please don't panic if you're looking at this and going, oh my God, that's so much information. It's all out there, fortunately, thanks to the wonders of technology, which still let me down. But hey, I might be a good strength coach, but I'm useless when it comes to PowerPoint. So These exercises are all there. Another thing that I really wanted to talk about very quickly is this is where you're going to think, hold on, he's contradicting himself. Those exercises that we just saw are what I'd call corrective exercises. And the fundamental difference is that when you're doing big movements, squats, pulls, pushes, you want to use those big muscle movements. You want to do the Russian strength training method. But for corrective exercises, so for example, strengthening the muscles that pull the shoulder blades back or strengthening the muscles around the knee, you need to do more repetitions. So I would say maybe 12 to 15. And once again, it's all on the YouTube pages. But it's kind of the icing on the cake. If you're doing so many of the big motor pattern movements, that will make you stronger. But you will start to get imbalances, maybe in the shoulder blades, etc. And so you want to counterbalance that. You don't always want to just do the big money movements. You want to sprinkle a little bit of corrective work on the cake, because then you're going to prevent yourself from injury down the line, because we all start to, get tight hip flexors or shoulders slump forward, and that's going to present problems in itself. So does that make sense? I mean, feel free to, catch me afterwards if there's any questions or queries and it doesn't make sense. Keep track of your progress, okay? The faintest of inks is better than the strongest of memories. Write it down. You're going to come away today and you think, I used to be able to, I've always been able to do this many push-ups. If you don't write it down, you're going to always think that's how many you were able to do. You will surprise yourself, okay, over the next coming weeks and months at what you're able to achieve. Write it down, because it will really motivate you as well. We always kid ourselves, oh yeah, I could do that. And then you suddenly realize, actually, if you look back, you couldn't. Breath work, that was a lovely session on breath work. I think after the PowerPoint didn't come through, I needed it as well. I was like, So breath work I could talk about all day, but I'm not going to. What I wanted to do very quickly was, have we...
30 seconds.
30 seconds. Oh, can't believe I've gone through all of that in 30 seconds. I did want to do some quick questions. Have we got time for questions?
Yes.
Good, because you might have quite a few. That initial presentation, the first time I did it, was about 1 hour and 15. So you can see that's me working at speed. Let me see whether there's... I'm a big fan, Vince will tell you, we've done Qigong and breath work, very, very powerful. I'm a big advocate of the Wim Hof technique, which has been shown to reduce inflammatory cytokines in the bloodstream. So yoga, phenomenal. I can't speak highly enough about it. I come from a Chinese martial arts background, so I'm more sort of Qigong. But all of those things, movement is key, and just finding what you like as well. I can't emphasize that enough. Don't feel like you've got to be pigeonholed into a box of, oh, I have to do this. Find something that you enjoy. Working with a fitness professional, well, that'll be good. The sad fact of the matter is that one thing I found is that there's a real dearth of strength training coaches who have this kind of interest or background. So, it's a pity. It's finding somebody who's good and who's prepared to really engage in conferences like this or learning online. There's no cookie cutter template for this. You say, oh, I've got 2 amyloidosis patients. That's like saying I've got 2 people in front of me, 2 completely different people. You can't go, oh, I'll bring out my amyloidosis program. You could have some template ideas, but everybody's different, and all of you will be at different points along your amyloidosis journey. So I'm not going to patronize people by saying there's one size fits all. You need to kind of work it into your own day-to-day activities. One thing I did want to finish on, actually, we won't go through supplements. Like I said, I've been very fortunate and blessed in my career to work with people with some very complex health conditions and issues, head injuries, all sorts of things. One thing we haven't touched on too much today, but I can't emphasize how important it is enough, is mindset. Okay, and the thing that I found is that these clients who are in pain, suffering, and have conditions that are completely out of their control, they didn't bring it on themselves at all, are the most committed, disciplined, and powerful people to work with. They don't allow negative or limiting beliefs or thoughts into their lives. They are very, very positive. They don't let other people tell them, oh, well, you won't be able to do this. They're always trying to forge their own path forward. So the way you view yourself, your mental focus, your own personal belief system, and how you bring that to will have a direct impact on your body and your physiology. You know, we all know that. Okay, I'm going to leave it there. Thank you.
Thank you, Alan. Thank you for this beautiful presentation. Thank you for your enthusiasm that really motivates all us lazy people to do more. I think that the key message here is that a tailored exercise, a tailored physical activity can be performed by everybody and will have beneficial effect on many, many aspects. And we have to start considering physical exercise as part of our care. I hope you enjoyed the session. Yes. And there is still time for a couple of questions. Yes? Stefano?
Bene, permettetemi intanto insomma, di ringraziare a nome, penso, un po' di tutti, come è già stato fatto da altri, l'organizzazione di questo convegno, che insomma così poi globalizzato, ecco la globalizzazione che ci piace, e soprattutto anche i medici, gli operatori che sono intervenuti e interverranno, insomma. In particolare personalmente io voglio ringraziare anche il dottor Guaraldi e il dottor Longhi, che sono i miei punti di riferimento per la loro professionalità, non sta a dirlo, cioè non sono io che la devo asseverare, ma per la loro disponibilità e anche capacità di relazione quasi amichevoli, direi, che per noi pazienti è molto importante, vale quanto il farmaco, insomma, posso testimoniare personalmente, credo forse anche a nome di altri. La domanda, anzi le domande, soprattutto riferite a questi due ultimi interventi, gli altri sono stati pure interessantissimi dei medici, ma degli operatori. È difficile, almeno per me, capire quanto, visto che c'è anche una necessità di automonitorarci, quanto sia la patologia che impatta sulle condizioni e quanto il tempo che passa, l'età che passa, insomma, a 70 anni non hai le stesse performance che avevi a 69, a 68 e così a ritroso. Quanto quindi può essere difficile, almeno per me lo è, capire che se non poi ho un tendine del bicipite rotto, il sovraspinato rotto, il tunnel carpale già operato e che di nuovo mi dà problemi, quanto siano quindi gli effetti della patologia e quanto l'età che passa, che come senti altri amici e persone si lamentano di questo, insomma. E chiederei se è possibile avere qualche indicazione in questo senso. So che non è facile perché poi ci sono gli esami forse obiettivi che lo determinano, però anche in funzione delle proposte prima sullo yoga, ma soprattutto queste di allenamento, insomma, quanto posso danneggiarmi facendo dei movimenti anche. Non so se sono stato chiaro nella domanda.
So I will briefly translate. So the question is, how can we understand which aspect are related to the condition and which aspects are related to aging itself, and how shall we address this issue of aging in this condition?
That's a brilliant question. I would say that there's a definite overlap because as we get older, we're going to lose muscle mass anyway. You know, some people have carpal tunnel syndrome, some people have osteoarthritis. What I would say is that if you are there's the danger of paralysis through analysis. If you look at what aspect is controlling your movement, for example, there's always the danger that you're not going to implement actions that could help it. I think if you're doing exercises following this particular format, there's no risk of harm, but also there's a definite potentiality for really improving your muscle function. How far? I can't say. You know, it's too much. It's such a complicated, multifactorial issue that it would be impossible for me to guarantee that there's straight lines between just the natural aging process. I'm losing muscle mass. That's just because I'm, you know, older now than I was 5 years ago. You know, we have this gradual decline. Or, you know, your hormonal levels will alter as you get older. But I would say that a simple answer to a complex question is this: strength training will always improve all those markers. The leaner you are, the better your blood sugar markers will be, your hormonal levels. I found that even just dropping little percentiles of body fat, for example, have improved my blood pressure, my blood glucose. So it's just something I think everybody should be doing. It's not just related to amyloidosis. Everybody should be focusing on strength training. You don't have to be in the gym absolutely killing yourself. Hopefully that answers it in a long way. It's a complicated question, but I would say just committing today. You know, I did this yesterday. I ran out of time, didn't get a chance to go to the gym, and I just did the same routine I'm recommending to you guys while I'm checking emails. Just do an exercise, take 3 minutes recovery, do another one. It's so easy. You can do it in your hotel room. You don't have to even head to the gym. If the gym is your vision of hell, then don't go there. You know, just do these sort of things at home, and that will hopefully. Okay. Yeah.
There is another question in there.
Désolé, je vais parler en français, qu'il y aura la traduction. Alan nous a montré des photos
Speak
de
in the
mouvements à faire.
Speak in the microphone. Speak in the microphone, please. In the microphone.
D'accord. Alan nous a montré des photos de mouvements à faire qui avaient l'air très très intéressants, mais qui sont passés très très vite. Et il m'a parlé de son site YouTube. Alors j'ai cherché tout de suite, mais je suis tombé sur un Alain Lévy qui n'avait pas le même physique que vous. Donc que fait-on?
I wish I spoke French now.
Que fait-on pour trouver ces mouvements sur Internet? Merci.
Merci. Oh, thank you. It's one of those moments where I think I wish I'd spent more time paying attention in my French class at school rather than just, you know, daydreaming. It's Alan Levy Personal Training on YouTube. I wasn't very original with it. Everybody's got to have a cool nickname like, you know, Knees Over Toes Guy or something like that. Now I'm just Alan Levy Personal Training. So you should be able to find it. And there are a whole load of videos on there and little talks, etc. So.
Okay, I think we have to close. Thank you everybody for joining this session. Thank you for all your inputs, and we'll move to lunch then.
Merci, danke. Ciao.